Good morning, everyone, and welcome to the first session of 2025 workshops series. We will soon start. Please bear with us. We will be starting soon. Thank you.
Good morning. Dr. Jibril, I had you speaking before.
Yes, sir. Good morning, sir.
Okay. So what's the updates?
Yeah, we can start, sir. I think we are up to 40.
Okay.
I've already introduced before you joined. Yes, sir.
Okay, wonderful. Thank you.
Yes,
I joined earlier, but a call came in. I had to pick it, so the network was not available to be on the platform. Thank you so much, Dr. Jibril. Thank you so much to all our participants. Thanks for joining us at the first workshop for 2025. It was an amazing session. Anyways, many sessions, the amazing sessions that we had in 2024, and it was interesting, really very interesting. The interest that participants have shown and how gained really in the year. So we hope that this year is going to be more interesting, and people have joined, have gathered knowledge, and to some extent some skills. I think it's time to put into action those things that we have learned, not just in the practice, but also in training others. So it will be important if those that have attended many begin to now train others, either through their own platforms that they can create, or if they want to join hands with Ray to serve as resource persons. I think it's important what we have learned that we begin to step it down. So thank you so much. You are all welcome. We always start with evidence-based practice because it's one of the pillars of the practice. For a very long time, our practice has been based on what we learned in school. So there are people that you find out that 10, 20 years after school, still practicing what they learned in school. I think practice has gone beyond that kind of approach. Every single day, researches are published, and the essence of publication of researches is for them to be used in clinical practice. And it's very important for us to now understand how we can be able to, even if we don't do the research ourselves, how do we get hold of the researches that have been done, published, peer-reviewed and published, that has shown either validity, reliability of assessment tools, or that have shown effectiveness of interventions. How do we make use of them in our patients? So I've taught this course, evidence-based practice, I think from 2013 or 14. Started teaching MSc students in Bayero University, Kano, and at a later time, extended it beyond the shores of the academic environment. I started having workshops and trainings, always emphasizing on using evidence-based practice in our practice. So, and mostly, I've also evolved. I've focused a lot on the theory, but I'm getting to the point that I'm beginning to see that we need to change and look at the practice even while having workshops. And therefore, I'm going to focus a lot on searching for the articles, looking at the articles, extracting the information, discussing how we can be able to apply it to our patients. So although there's still going to be the theory part, but we're going to do a lot of practicals. And I want to encourage you to be active in the learning process. In education, active learning is very important because passive learning, at the end of the day, you retain only possibly about 10 to 15% maximum of whatever is taught. But when you are active, depending on how active you are, you can retain up to 70 to 90% of what is taught. And therefore, I want to encourage us to be active. And this year, we have also introduced another session that we'll have in the evening. And in that session, there is not going to be a lecture at all. It's going to be a hands-on thing where the participants search for articles, extract information, and discuss how to apply it on patients. And the facilitator will only be there to guide. But today, and that is why today I might not really push so much for that hands-on part from the participant. Let's understand the concept. Let's see how it's done. But I think it's going to be on Wednesday. I can't remember the date, but if it's on Wednesday evening, whatever day it is, we are going to come back and we will have the hands-on with participants doing the search and extracting information and discussing how it's going to be applied on patients. So thank you so much for joining us today. I'm going to be fast because, as I've said, there's a lot. Evidence-based practice course is something that when I was teaching in the MSc program in BUK, it's a semester course. We have 2 hours every week for 12 weeks. And therefore, it's something that's difficult to cover everything within just one day. So I'm going to be fast, but I'll focus more on the most important parts, especially the ones that we are going to deal with in the hands-on. So before we start, just want to ask these questions. What are your views of EBP? What are your experiences? And what do you hope to learn from this workshop? So you can raise your hand. As I've said, I want to encourage participation. So I would like to see at least a few hands, get comments, and then we'll get to the introductory part. You can raise your virtual hands. Bear with me too. I had serious catarrh a few days back. Still have a little, struggling with it a little. So bear with me if as we go through, my nose gets stuffy or my voice changes. So can we have a few hands? I believe most of us have used evidence-based practice. I believe if we have not used it, we have read about it, we have heard about it. What are our views about it? What are our experiences? So let me just pick a few randomly. Abdul Aziz Arowolo. Sorry if I pronounced that name wrongly. Abdul Aziz. Can you unmute?
Oh, okay, good morning, sir.
Yes, good morning.
Okay, so my little knowledge about evidence-based practice is basically I'm looking through research, both journals and like clinical how would I say it, clinical practices that have worked in the past for treating certain conditions that have backends basically, and not just doing things from like the head mentally. So that's my idea of it.
Okay, sorry, come again. I think the network was
okay,
not...
Can you hear me now?
Yes, I can hear you now. Yes.
All right, so I said it's a way of treating by using researches from journals or clinical experience.
Good.
To deliver treatment of conditions and not just using interventions out of nowhere.
Okay, wonderful. Yes, that's a good one. That's very good. Evidence coming from research journals. So that's a very good one. It's a significant part of evidence-based practice. So or the research alone does not constitute evidence practice alone, but that's a very significant component. Mr. Nelson Ole.
Good morning, Prof, and good morning, Apex. My concept and what I expect from this workshop is, I know evidence-based practice, has to do with the consideration of about 3 pillars that help us to deliver quality treatment to our patients. One, you have to consider the research that have been done in those areas, particularly in conditions that maybe you're interested in? Have there been any research done in that area? How does it apply to this patient? Then secondly, we also have to consider the experience. What experience do we have as a practitioner? And then what are the patient expectations? Then putting all these things together, how can we now appropriate the best treatment, considering the patient in question, that how he will not benefit from what we do. And when we are talking about the evidence, there are different levels of evidence. Some might just have to do with expert opinion or maybe experiences. Then I think from what I've learned previously, the highest form of evidence has to do with RCTs and meta-analysis, which is the highest form of evidence, and apply it to the patient that we want to manage. Then my expectation from this workshop is to actually have a better understanding of what I have heard before and appropriate it easily, so it becomes easy for me without struggling, how to search for this evidence over time. Thank you, Prof.
Network was bad when you were talking about your expectations. And in fact, before you even mentioned expectations, I wanted to that we have done on evidence-based practice. Why are you still attending again? And you have started mentioning why, but the network was bad. But are you still there?
Yes, Prof, I'm here.
Okay. You are talking about expectations. Can you say that again, please?
Yes, I say my expectation is actually not been very easy for me to appropriate this. Okay. Yes, I'm not efficient in it, so I want to get better.
Okay, good, wonderful. Because that's why I wanted to ask. And say I know you have attended more than one, and from your submission, I know it comes from the knowledge of it, having attended or read about it. So that's good, because I want to know, how do we improve? How do we get better? So thank you so much for those comments. I think we'll go straight into the slides, begin to talk about evidence-based practice. But I just want to ask participants to please drop your professions on the chat forum so that I'll be able to know if there is diversity that I need to consider while discussing. In the past, as I've said, I first made these presentations or taught this course in MSc. It was for physiotherapy. A majority or almost all were physiotherapists. So usually the slides focus more on physiotherapy. So, but this time around it says for health professionals. So I would like to know if there is a diverse group that will help me to be able to focus on that diversity, not just one profession. So please, the coordinators, please help me go through so that I will be able to know if there are other professions apart from physiotherapists that have joined us. Thank you. Yes, so introduction, it's an important aspect of healthcare delivery. Very, very important aspect. The principles have been shown to lead to improvement in quality of healthcare. Whatever it is in health that we are dealing with, it's about evidence that it leads to quality health care. And evidence-based practice has been shown to lead to improvement in quality of healthcare. And therefore, it's important. It's something that we should focus on. It's something that we should do. Now, because of its importance, the National Academy of Medicine, a roundtable on evidence-based medicine, required 90% of clinical decisions to be based on evidence. This was by 2020. So by 2020, 90%. So by now that we are in 2025, possibly they would have increased it to almost 100%. that every decision that we take must be backed by evidence. Every decision that we take, we must consider our experience. Every decision that we take must consider the patient's preference and the perspective of the patient. So that's how important it is in clinical practice. And because of its importance, organizations were formed from that concept. In England, you would have heard of National Institute for Health and Clinical Effectiveness. It was because of evidence-based practice that they established that organization. In Scotland, a similar organization called Scottish Intercollegiate Guideline Network, while in the United States, they called it United States Agency for Health Research and Quality. Considered current-based evidence. And that is why in the two definitions that were given earlier, it was the earlier definition, the initial definition, that was looking at current-based evidence. Mr. Nelson mentioned the hierarchy of evidence. And in that hierarchy, there is a level at which it's called high-quality evidence. And there is below that, it's called low-quality evidence. We are going to look at those levels. So if you have your evidence that you get that you want to apply on your patient, it falls within the hierarchy of high quality evidence. That is when your practice is evidence-based. Anything below that is not evidence-based. That is the current perspective of evidence-based practice. But initially, in as much as there is an evidence, even if it is a low quality evidence, but that evidence that you use is the best at that point in time, it's evidence-based practice. But now things have changed. You can use the evidence, it's the best you can get at the moment, but your practice is not evidence-based until you get high-quality research. If it's not available, you'd go through the research, produce results, use it. That's when it would be evidence-based practice. The initial definition also did not consider your ability to apply the evidence on the patient. It's one thing to have the evidence, but it's another thing to learn how to apply it on your patient. So if you don't know how to apply it on your patient, it's not evidence-based. So that initial definition did not consider that also. Then number 3, it also does not consider the perspective of the patient. So you can have the evidence, you want to apply it to the patient, but the patient does not understand your perspective and they don't cooperate. And at the end of the day, the evidence is not important to them. That also is an important aspect of evidence-based practice, the perspective of the patient. The initial definition did not consider that. So it was updated. Process of shared vision. So it's not just the therapist, it's a shared vision, decision-making between practitioner, patients, and other significant, that is possibly the caregivers, relatives, based on research, the patient experience and preference, clinical expertise or know-how, and other available robust sources of information. Now, even in this definition, it does not consider high-quality research. It only says based on research, meaning the initial and this updated one are similar when it comes to the issue of the evidence. It is just looking at the current-based evidence, not high-quality research. And therefore, these are the 3 components of evidence-based practice. So high-quality clinical research, and that is why when in MRTB we say that someone must have CPD units in research. And people will think we are not in the academia. Why do we need to show evidence that we know how to do research or we know what research is all about? This is the reason. Evidence-based practice, no one will tell me that it is for academics. Evidence-based practice is about the practice. It's about seeing patients in clinic. And if for you to say your practice is evidence-based, you must use high-quality clinical research. How can you use what you don't know? Therefore, it's very important for us to understand what high-quality clinical research is. How do we get it? How do we apply it to our patients? If it's not available, how do we do it? How do we do it if it's not available? Because remember, we said if it is not high quality, even if you use it, it's not evidence-based. And therefore, if the high quality one is not available, what do? We just have to do it. So that's the evidence. We'll come to see what high quality constitutes. What is high quality? Then when you get it and it's high quality, you read through, you see the procedure applied to patients in that particular study. Then you learn how to apply the procedure on your own patient. And that is what practice-generated knowledge is. It's not just about the knowledge, but it is knowledge that is generated through practice. So you learn how to apply it to patients. Then you now explain to your patients, let them agree with you that the result in that paper, the procedure in that paper, clinical research paper that you have gotten, that they understand it and they agree with you, they give you consent, and then that's what completes evidence-based practice. Now, why is it important? Safest and most effective interventions, best possible clinical outcomes. If you don't do research, it's very possible you'll apply something that may appear to be working, but it's not working. One of the World Physiotherapy Conferences asserted that infrared and some other heating modalities are not effective. And in some countries, they don't use them at all. Why? Because it's research that has shown that it's not effective. Structural and systemic approach to clinical decision making. Through evidence, we'll be able to have a systematic approach to clinical decision making. It offers patients and colleagues reliable information. Patients read papers before they go to the hospital. So they know about procedures. They can't apply them, but they read about them and they know about them. And therefore, if they come to you and you're doing an assessment, they'll say, why are you not using a particular assessment? Why are you not applying a particular intervention? 2012, 2013, I was seeing a patient. The son is a radiologist. And he said, he was observing me. The patient had back pain. I mean, no, that I spent with my master's and PhD, I was focusing on neuro. And at that time, there was no specialization really strongly where I practiced. And therefore, there was this patient, say, help see the patient. I looked around, okay, who should I call that is in auto? So, okay, let me see the patient. And while I was treating the patient, using the traditional methods of treating the patient, the son asked, are you aware of stabilization exercise? And I sat down and I was listening. I said, no. And at that time, I was not aware. And he said, why don't you reach out to one of your students? I was a co-supervisor in her undergraduate degree. She was being supervised by Professor Akindele, then Dr. Akindele. And the radiologist was a co-supervisor because they were looking at the multifidus muscle and its activation after application of stabilization exercises. And he found it to be very, very interesting that before she applied the stabilization exercise, he checked the level of activation using ultrasound. And after she applied, he also assessed the level of activation of the multifidus muscle. And he became very, very interested that, wow, see, the level of activation has increased. And at the end of the day, they collected their data. I think at that time they had not published it, but at least the data was out and it showed significantly that there was an activation. And the tests that she did to find out if that multifidus muscle was not active and it needed to have stabilization exercise for it to be active, he got to know about those tests. He's a medical person. And therefore, in his father, he can try those tests, whether it's quackery or not, and he will see whether the father is a candidate for stabilization exercise. And I came in. I did all the traditional procedures that we would do those days. And he saw that I did not do that. And he knows there's an indication for it. And he was questioning me. Are you aware of stabilization exercise? So it offers patients reliable information. If you can't offer reliable information to the patients will offer you the reliable information. Luckily for me, at that time, I just came back from the UK, 4 years. And it's a tradition in the UK, if you don't know something, you just say, no, I don't know. And I told him, I said, I don't know, but I will go and find out. The moment I left, I got, I saw, rest in peace, Khadija Akib. She died some years back. That time I went to a and I said, who is Khadija Akib? I said, she's the one. I said, I heard that there's something you know that I can learn from you. And she was afraid. This guy, they said, he's the first PhD in the world now. He just came back. I mean, cut a long story short, it was evidence-based practice that's the importance. It offers patients and colleagues reliable information. I didn't have that information. I could not offer that reliable information. The patient relative offered it to me. I had to go back, learn, because we sat with her. She gave me the information. She did the practical in my presence. I learned about it. And up till now, I appreciate that. Truly, truly appreciate that. I'm not in auto, but if I am, that would have been maybe an eye-opener for me to be able to do more in the area of clinical practice. And when you go forward rounds, but what you do to captivate the minds and attention of your other medical colleagues and other health professionals is to speak about the things that are within your scope of practice and show the evidence. And you find out that all those issues of looking down upon me or not will not be there. So giving colleagues reliable information. So from this evidence, it has been shown that this is effective in treating this. This is a form of communication, reliable information, because it comes from evidence. No one is going to dispute it. Professional ethics. You have two outcome measures. One is more reliable and valid than the other. It will be unprofessional if both of them are available to use the one that is less reliable and less valid. The same thing with interventions. You have two interventions. One is more effective than the other. It is unprofessional to apply the one that has low effectiveness. Value for money. You are in private practice. Believe me, if your patient knows that there is an evidence, high quality research that has shown that if something is applied to them, they will get better, believe me, they will pay you more than if you are only using traditional means of treatment. It bridges the gap between theory, research, and practice. Get rid of rituals. Some of the things that we do are just rituals. No evidence at all. They are just traditions. I keep giving this example. Someone has challenged me, and we are discussing right now. Say someone that has stroke, you want to stand them or walk them, and they have the potential to recover, and you still want to be standing them, walking them with back slap. That's just a tradition. Where is the evidence that it works in helping to ambulate them? The brain will just only learn how to stand using back slap. And when you remove it, the knees will collapse because the knees have not learned, or the brain has not learned how to maintain the knee in extension during standing. Whenever a patient has stroke, they will say bridging exercise, bridging exercise, bridging exercise. What is it that shows that at a particular level that the patient needs that? At what level is it that the patient does not need that? So evidence-based practice helps us to get rid of rituals, traditions, and individual clinical experiences. Because I've applied it on one patient, it works. I want to now apply it on all other patients. We'll ask my students to be applying it on all other patients now. Now, the next thing that I wanted to do was to pick number one, which is high quality research, and show the levels of the hierarchy of the evidence. So when do we say this is high quality? When do we say this is low quality? But I've come to realize that if we understand the concept of components of patient management, the hierarchy will be understood more. And that is why I brought this slide. You'll still see the slide when we come to the steps for applying evidence-based practice on patients. But I'm going to explain this so that when we are looking at the level of evidence, because the levels of evidence are the research designs that are used in the researches. So those research designs, we'll understand them more if we understand the components of patient management. But before, anyway, I've been asking this question, so let me not spend a lot of time. Whenever I ask the question, what is the difference between treatment and management? I get a lot of funny responses. People difference between as just both of them are about treatment, but in treatment possibly you are just treating the impairment, but in management you are taking it further in the treatment. But that's not the difference. Is that management has 6 comes to you. You begin to observe when they see they have pain. You have started management. Observations that you do, the tests that you do, they are all part of management. So examination is a component of patient management. And everything you do in your clerking process is part of examination. So the patient comes, you observe the way they walk, you observe the way they sit, whether there's pain. You ask them questions about their biodata. What's your name? Is part of examination. What's your age? What's your address? What's your gender? You now go to possibly past medical history, family social history, drug history. You ask for the chief complaint. You go further to take the history of the patient. You go to the examination. You do your observation. You do your spatial tests. You get your radiological investigations. You get your laboratory tests. Everything you do as part of the clerking before you diagnose falls under examination. Now, there is really a lot of confusion between the difference of management and intervention, but also between examination and evaluation. So examination is the observation you make and the result that you get. So you measure the weight of the patient, and it says it's 60 kilograms, for example. So the weight of the patient, you use your weighing scale, get on it, you take the reading 30 kg, you get a result. That is examination. You ask the patient a question. Where exactly do you feel the pain? He shows the location. You ask about the type of pain. They give you an answer. This is examination. You use your blood pressure monitor. You assess blood pressure. You get a result that says 120/80. That is examination. But you do examination so that at the end of the day, you reach a diagnosis. An examination is not something that you just get the tests and the tests, one test will just give you a reading and then you get a diagnosis from it. No, it's far from that. Because diagnosis will have a diagnostic criteria. And that diagnostic criteria, out of all the symptoms and signs that the patient has, say out of them, an example, Parkinson's disease, say the cardinal signs of Parkinson's disease are tremor, bradykinesia, the postural problems, the rigidity, so about 4. But are they the only symptoms and signs that are there in Parkinson's disease? No. There are more than that. And a patient can present with this and other combinations of others. While another patient will still have this and have other different ones. Cognitive problem may be there. Inability to stand or walk will be there. These are all things that can be presented in different ways in patients. But whenever you say the patient has that condition, he must have those cardinal ones that are part of the diagnostic criteria. An apology, I will be giving examples with medical, medical diagnosis, because it's not very common amongst us doing physical diagnosis. We are going to do a workshop on human movement system. And we are going to discuss the physical diagnosis. And it is from there that we'll see the difference between physical and medical diagnosis and how we make physical diagnosis. So if I'm now to give examples on physical diagnosis, then I will have to go back and begin to explain the concept of physical diagnosis. But the terms that we are familiar with are the medical ones, and that's why I'm giving an example with them. So bear with me. Now, between the time that you have examined and you now want to make a diagnosis, there is something in between. You have to interpret the results of the examination for you to be able to now make the diagnosis. That interpretation of the results of the examination is what is called evaluation. And this is where we come in as professionals. The organizers asked me if technicians can join this class. And I said, the scope of practice is for those with a degree. And it is because of these discussions about evaluation. When you examine, you must interpret. How do you interpret? You use your clinical reasoning to interpret. And I think the next workshop, possibly next Saturday, is going to be on clinical reasoning and clinical decision making. This is what characterizes a professional. So evaluation is the interpretation of the results of the examination to help us narrow down and get a diagnosis, which is one condition. So let me give an example. I deliberately mentioned the issue of weight under examination. When you take the weight of a patient, it's an examination. You weigh, you get a result. The result says 60 kilograms. You take the height of the patient is 1.67 meters. So this is our examination. But it's at the level of risk factors that we are doing that. We want to know, is this patient having things that will make them to be at risk of having, for example, cardiovascular diseases or musculoskeletal, such as osteoarthritis, or cardiovascular diseases, such as heart disease or hypertension or whatever it is. Because obesity is a risk factor for having such system problems. So we want to interpret the weight and the height, because the weight after examination cannot give us an indication of whether the patient is obese. It can't. Let the patient be 120 kg. Can we say that patient is obese? No. And is weight enough to give an indication of obesity? No. It's just an examination, you have the result, and that's it. You must interpret it. And therefore, that interpretation is what evaluation is all about. And that is when someone now does a research to see, how do I interpret the weight and height of a patient to give us an indication of that patient is at risk of having cardiovascular diseases or some musculoskeletal diseases. And he said, well, when we take the weight, right, it will give us the interpretation. So what is the result? How do we interpret it? When the result is less than 18, the patient is underweight. If it is between 18 and 25, the patient has normal weight. Between 25 and 30, the patient is overweight. Above 30, the patient is obese. I therefore take the weight of the patient, that's examination. I take the height of the patient, that's examination. But how do I evaluate? My evaluation will come when I do this calculation, I get the result, I now interpret it to say that yes, this patient has obesity because his score is over 30, and therefore I count this patient as being at risk of having cardiovascular or musculoskeletal conditions. So that is evaluation. And this is something that we need to imbibe because we don't do it at a higher level as medical rehabilitation professionals. So that's evaluation. Another example of evaluation, when you do the clerking, you just keep asking questions and you are recording them. Initially, you ask about the age. The name, of course, name, age. So this patient is 60 years old. 60 years old enough does not mean that patient will have any condition. Just 60 years old alone. But when the patient, now you said gender, it's female, it's adding more suspicions. Age, 60 or 70, gender, female. Then you now take these particular issues about obesity. You add that. You now ask question about smoking. And the patient smokes, but not just smoke, smokes at least 10 sticks in a day for most days in the week. The patient takes alcohol. The patient's lipid profile is high. Oh, no. My interpretation is that putting together all this, the patient is seriously at risk of having a cardiovascular disease because these are all risk factors of cardiovascular disease. This is an evaluation. The examination is just to ask the question and drop the answer. Ask the question, drop the answer. But looking at it, so another example, this patient is male, 35 years old. The type of job, construction worker or driver. Continue like that. This put together, my interpretation is that this patient will be at risk of having musculoskeletal problem. Because the risk factors are that when you have lower age and it's a male, and then the type of job. So this is evaluation. I'm not just examining, but I'm looking at the results, putting them together and making sense of them. This is evaluation. At the history level, I'll give an example with neuro, but I know earlier I've tried to give examples across board. And from what I've seen on the screen, most of the responses say physio. And therefore, I've seen public health scientists. Yes. Okay, wonderful, yes, I've seen that. But all this, I think, are relevant because when we talk of the job of a person being a driver and they get low back pain, for example, which is a musculoskeletal problem, it's something relevant to you as a public health scientist, isn't it? Because I'm doing public health right now. As masters of public health. So I can see the relevance there. So just call my attention as I speak if you want us to have a discussion on any of the professions that are here that have not identified themselves. Yes, so that's evaluation, interpretation. Yes, so the example I wanted to give at the history level, as I've said, I'm going to give an example with neuro example. At the history level, the questions that you ask is examination. So you ask the patient, the chief complaint is about weakness in the part of the body, upper limb, lower limb. So this weakness, so I have weakness, it's weak. So you now ask the question, when did you have that? 3 months ago. Over what period did that weakness reach the maximum that you have ever had? And the patient says, wow, within 30 minutes. So what does that say? It's just an examination. That's just a question. And they have given an answer, 30 minutes. That's examination. What can you do with that to help you narrow down to a diagnosis? Nothing. But if you want to interpret anything that builds up over minutes or hours, usually is an acute affectation. Acute affectation. So the patient has weakness or sensory disturbance. And within minutes or hours, it builds to the maximum. So meaning, for example, complete paraplegia, or paraplegia or whatever type of plegia, because we're talking of weakness. Complete, within minutes or hours, is called an acute affectation. And usually acute affectation is a vascular problem. When the patient says it started 6 months ago, over what period did it get to maximum? And the patient says, well, it took between 3 to 4 months, or 4 months to 5 months, 5 months to 6 months. Oh, this takes long period. Anything that takes place over months or years usually is a degenerative affectation. It is degenerative. And when the patient says within days to weeks, usually this is an inflammation. So you have in the brain, due to an injury, fluid continues to move out little by little by little. It takes days to fill up a cavity, and then you'll now begin to have compression of the brain, and you'll now begin to have symptoms appear, or reach maximum, or the symptoms to reach maximum. So that is an inflammatory affectation. So what you are doing now is not just the result. You have the result, you are interpreting the result using your clinical reasoning. Then the next question will be the pattern of progression. From the time you had it, you said 6 months ago, right? Yes, 6 months ago. Over that period that you have had the maximum, was it getting better or was it getting worse? Of course, common sense will say it gets worse. So over months. So it happens, the onset of the disease is chronic. It takes months before it reaches the worst. And it continues to get worse over time. That is a degenerative condition. But it's an acute presentation because it happened within minutes or just an hour. And the condition from that time until now, it continues to get better. Vascular conditions are the ones that have such a presentation. And therefore, 2 questions. I'm giving you an indication of what type of neurological disease that the patient has. So acute with getting better, vascular, chronic with getting worse, degenerative, subacute, which is days or weeks, with fluctuation. Sometimes it gets better, sometimes because even your position and some things can help reduce the pressure, and therefore it's the symptoms will go down. When you change another position, the pressure builds in the brain, it gets worse, it keeps fluctuating, and it is within days and weeks that it develops. This seems like an inflammatory. This is evaluation. This is evaluation. So you have your results, they don't say anything. You have to interpret the results for it to help you to narrow down. Now, what have we done in this neurological condition? No, even the other ones that we have had. Patient comes to you, it can be anything. But just from questions, what's your age? I'm 60. What's your gender? I'm female. Do you smoke? Yes, I smoke 10 sticks per day. What's your lipid profile like? You said you did tests. You usually do your tests regularly. What does it say? It says the lipid profile is high. Okay. Oh, all these things put together. Obesity. Your weight is 100 kg. Your height is 1.5. And therefore, from our calculations, you have over 30. All this put together. I think this patient is at risk of having cardiovascular disease. You are narrowing down from all systems to now suspicion that the patient has cardiovascular disease. That is evaluation. It helps you to narrow down from an examination that you have done, thinking of everything can be possible, to now thinking of a particular system of the body affected. That is at that initial level. But by the time you get to history, you have gone beyond thinking of systems. the systems you suspected at the earlier stage, you now want to narrow down from a system to a particular category of conditions under that system. And that is why when I chose neuro, I said onset of the disease, its pattern of progression. I'm now saying, oh, this is vascular in nature. So even under the neurological condition, my evaluation is narrowing down to a vascular problem. My evaluation is narrowing down to a degenerative problem. So this is what evaluation is all about. As you continue to narrow down, you are going to get to a stage where you now observe a particular diagnostic criteria for a particular condition. And that is why when you now say, this is the diagnosis. So diagnosis is when you establish the presence of a particular condition out of many that are differentials. By the time you get your diagnosis, the next thing is you want to know from all these tests and assessments that I've done, how long will it take my patient to recover? And that is when you now begin to look at prognosis. So prognosis. And what are the things that you look at in prognosis? There are three things. Number one, there must be a recovery, and that is your interest. There must be a recovery, and that recovery should be specific. What are the symptoms in that patient? What is the chief complaint of that patient? Is it pain? Is it weakness? Is it inability to walk? Is it inability to sit? Whatever the patient's chief complaint is that you want to target your interventions to solve, you are now asking, when can that particular symptom recover? And the recovery must be specific. Is it to sit? Is it to stand? Is it to relieve the pain? Is it to relieve swelling? Is it what exactly is it that you are after as part recovery? The second thing is how long does it take to achieve that particular recovery? Maybe initially you start thinking of when will the patient sit independently. Of course, the timing will be different from when the patient will stand independently. You might set this prognosis for each of those recoveries, or you might pick the one that should come first and focus on it. But at least you are looking at a recovery, and you are looking for how long it takes to have that recovery. Then number three, what are the factors that determine how long it takes to have that recovery? Or what are the factors that determine what recovery I can be able to have, or the patient can be able to have? So for example, the age of the patient. The higher the age, the less your expectation of the patient being able to stand or walk because of degenerative changes that come with age. The severity of the condition. The more severe the condition, the longer it takes for recovery. Then other underlying diseases. This is a patient that has stroke. Had severe osteoarthritis. Because of that underlying disease, it might affect how long it takes for the patient to be able to walk independently. So this is what prognosis is all about. We need a recovery. We need the time or the period it takes to understand the factors that will help us to know the timing and the level of the recovery that the patient will have. So it is after doing all this that we now begin to look at intervention. What intervention do we give to the patient? Why do we even look at prognosis before intervention? So that we'll be able to know, can the patient even recover, or are we going for compensation? This patient has complete spinal cord transection. Are we going after recovery? No, we are going after compensation. But it's partial. So that we'll be able to know what intervention do we give to gradually move that patient from the level they are to the level that we plan for them to get to before we discharge them. Then the intervention, of course, will come. And our intervention will depend on the symptoms that we have recorded. Just because a patient has a condition that has 40 symptoms, you don't have to go treating all the symptoms. You only select interventions for the symptoms that are available in that patient, meaning the diagnostic criteria plus others that are in that particular patient. In another patient, you'll have the diagnostic criteria and another combination. And therefore, every single patient must be given intervention that is specific and unique to what they present with. There is no single package that you give to all patients. When this patient comes, give him that package. When this patient comes, give him this package. No. The assessment will determine what this patient has that this patient doesn't have, and your intervention should be directed towards the uniqueness of the presentation of every single patient. Then lastly, the issue of outcome. Now, my public health colleague, you will see a lot of relevance when it comes to outcome. What are we looking at this level of outcome? A patient comes to me with low back pain or neck pain, and that patient is a porter. In their village, what he does is to go to market and he takes bag of beans or bag of whatever from one shop to another shop. And because he's very strong, he can take 2 bags. And it's not just taking 2 bags. He can take 2 bags 10 times in a day. From one shop, he takes 2 bags, he takes it to another shop. He'll go back, he takes 2 bags, he takes it. He does that 10 rounds. Then he gets neck pain. And he now comes to the hospital. And as a clinician, you examine the patient, you evaluate, you diagnose that the patient has lumbar, whatever, for the medical person. While for the physio, you have your own physical diagnosis. For other professions, they make their own diagnosis. You get the prognosis. You think, because the severity is not much, the patient should get relief of the pain. You strengthen whatever muscles you want to strengthen, you do whatever it is that you want to do, and you think you can discharge the patient to go back to their job. You have given the intervention. Can they go back and still continue to take 2 bags of beans, 10 rounds in a day? This is where outcome comes into play. This patient that is in the community, how has his lifestyle changed as a result of the condition? How has the management given in the hospital helped his outcome to improve? So possibly you are a physiotherapist, you are in the clinic focusing, you have discharged the patient, you forget about the patient. The public health professional follows that patient to the community and he's looking at his outcome. How has his lifestyle been regained? You now send him back. Because it's multidisciplinary, the medical doctor, the occupational therapist, the public health specialist can now sit down. From our expect that he can go back to taking 2 bags 10 times in a day. No, he can't. Okay, what is it that we think he can get down to? 1 bag 15 times, or 1 bag 20 times, or 1 bag 10 times. But what can he be able to do now? He can only take 1 bag 5 times. So what do we need to do to take him to that level of what we think he can get to, even though we know he can't get back to what he used to be in the past? So we discuss. And then we put him through so that the outcome will now help him with his lifestyle as he gets back to the community. So these are the components of patient management. Because if you are talking about evidence-based practice, there is no way that practice would be evidence if you are only using evidence-based practice for intervention. Because at the end of the day, you will select high-quality research. You will learn how to apply it. You will convince patients. But at the end of the day, that is not the problem that you are trying to solve. Because you have not done good examination, a good diagnosis, you have not gotten the proper prognosis, you are just intervening on something that does not even exist. That's just like the example I gave you with that patient who has a radiologist as a son. What I was treating was not the problem that the patient had. He needed intervention on something else. I was given intervention for something else. The patient will continue to come until the patient gets tired and discharge themselves. So I think it's important to understand the components of patient management. This is what shows professionalism. You're a professional. You can examine, you can interpret, evaluate, you can make a diagnosis within the scope of your practice. If you're a medical doctor, you make a medical diagnosis. If you're a physiotherapist, you make a physical diagnosis. If you're a public health professional, you have your own diagnosis. Everyone has their own diagnosis. Make diagnosis within the scope of your practice. If you're a physiotherapist and you say this patient, at the end of the day, the patient's diagnosis is lumbar disc prolapse. It's not the lumbar disc prolapse that you treat because that's an organic pathology. If you say the patient has cerebral palsy, you don't treat cerebral palsy because that's a medical diagnosis. And the same thing with the medical doctor should make diagnosis within their own scope of practice. And everyone should make diagnosis because that's what you treat. You only diagnose what you can treat. What you can't treat, don't make the diagnosis. Suspect it's there and refer to the person that will treat to make the diagnosis. Don't waste the patient's time. So this is components, or these are components of patient management. Let me ask if there is any question at this point before we look at the next stage, which is the research pyramid. Any question with regards to the components of patient management or any other thing that we have looked at earlier? Raise your virtual hand. Okay, Mr. Nelson. Go ahead, please.
Thank you, Prof. So far. Prof, please, I have a little area I want to get clarification on. Okay. You just discussed on the aspect of outcome.
Yes.
Which has to do with the best you think that the patient can get back to on recovery.
Yes.
And in evidence-based practice, you also talked about shared decision making.
Yes.
And we know that we live in a society where some patients, when you tell them the reality of what you think they can get to, they have expectation that after their condition, they're going back to what they used to do. And now, after your assessment, examination, diagnosis, and prognosis, and you have discovered that they cannot get to 100% of what they used to be, maybe it's like 50, 60, or 70%. Yes. And understanding the psychological implication of our patient, that when they get to know that they can't get back to where they used to be, it might begin to weigh them down. How can we handle situations like this? Should we hold back some information or outrightly tell them what we feel is the best they should have to know, even though it might not make them happy?
Good, very good one. Number one, that is why we say evidence-based. When you have an evidence, there's something called clinical prediction rules. There is a way that researchers have shown that in a patient that has this level of these symptoms and this level of these symptoms, this is what they achieve at the end. You will have a cohort study. But at the end of the day, when this study cohort has been done, another cohort study has been done, a number of them have been done, you now have a systematic review. At the end, you may have a meta-analysis. And after that, you may even have a clinical practice guideline. These are levels of evidence that are way at the top. And therefore, if you are speaking to the patient from the perspective of the evidence and how strong the evidence is, and now we have to also consider how we present evidence to patients. Because if you are in the Western world, almost everyone is educated, everyone understands research. You can be able to speak about the research in a way that you'll speak possibly to yourselves as professionals. But here we must also look at the limitations. And that is why there is a course called Psychological and Social Constraints in Health and Disease. When I was doing my master's in the UK, we had that course. Oh, and I enjoyed that course because it's looking at your patient's psychological and social issues that can serve as constraint to you achieving what you want to achieve. And how are you empowered as a professional to be able to now consider their psychological and social constraints so that you can be able to now carry them along and also empower them to be able to get to that level that they will understand and comprehend and accept whatever it is that you are presenting to them. That is why the model of biopsychosocial model is very important in healthcare. And that is why in professionalism, there is the issue of explaining things to patients and getting their consent. It's not just a research that you have an information sheet or a consent form. Even in clinical practice, you explain to the patient, and at the end of the day, they sign that they agree. So if they refuse, you can't force them because you need their consent, but you need to continue to engage them, explain to them, use those skills that you have in psychological and social constraints in health and disease to be able to direct them. And I can see Mr. Dawood raising his hand. I believe the concepts of public health, I'm doing public health as I've said right now, and I can see a lot that we can be able to learn from to be able to influence our patients, because that word influence, the issue of outcomes, and so many other terminologies that are there in public health, you'll find out that they are going to help you a lot in being able to direct the process so that you can achieve the maximum you can achieve between you and the patient. But of course, you have to give the patient enough information for them to be able to give that consent that is required. Very, very important. So let me ask Mr. Abiodun Dawood to speak, or Dr. Abiodun Dawood, whatever the title is. Please go ahead and speak.
Yeah, thank you so much, Prof, for this wonderful workshop. I just want to have a different question from what you just told us.
Okay.
Just want to know if there is any relationship between prognosis and outcome, because majorly, particularly in the UK, as you just mentioned, is always part of their ethics. If you want to actually take on a particular patient, particularly as a physio, you need to know what the baseline is, so that at the end of the day, after your intervention, you want to compare if there has been any progress or not by weighing it with what the baseline is. So that actually led me to asking you if there is any, relationship between prognosis and outcome. Thank you so much.
Thank you. There's a very, very significant relationship between prognosis and outcome. And I think if you look at all these components of patient management, all of them are related one way or the other. Now, for you to be able to know what a patient can achieve going out there, remember under prognosis, we talked about the factors that will determine what recovery you can have, and then the period over which you can have that recovery. And that recovery, remember I also mentioned that it all depends on the things that you are looking for as a plan for the patient. And I said you can break them down. For example, this particular patient, right from the beginning, your outcome, overall outcome, will be that this patient should be able to go back and be able to take 2 bags of beans 10 times in a day. That would be possibly the ultimate outcome. But then, to get there is just like the ICF, International Classification of Function. Initially, the patient is presenting with an impairment. But after you treat the impairment, you want to see how the impairment affects his ability to do things. You now focus on disability. You now want to see how the disability affects his participation, and you now want to focus on handicap. So the ultimate goal is the handicap, but you don't start with your goal as the handicap. You start with your goal as the impairment, but when you treat the impairment, your next goal is your disability. And then after disability, your next goal is participation. So that outcome is now going ahead and looking at the overall outcome, which is the participation from what I've explained earlier. But it is through prognosis that you are going to select what you are aiming for, what factors will help you to be able to reach there, and then how long it will take you to reach there. So all this will be considered in your planning of your management of the patient so that you can work on something realistic, not something that cannot be achieved. And it is prognosis that will. So meaning prognosis has a very strong relationship with intervention. What interventions do I give and over what period do I give them for this patient to be able to move from this level of recovery to another until we get to that ultimate goal. But what is the ultimate goal? Is the outcome. So there is a very strong relationship. Prognosis related to intervention, intervention related to outcome. Thank you so much. These are all very relevant, realistic areas that we should look at in our practice. Thanks a lot. Please, if anyone has anything to add instead of questions, please feel free, because I can learn from here also. So if you have comments, feel free to just give comments and add to what I've talked about. Nasir Hassan Musa, your hand is up.
Thank you so much, Prof, for this very good and educative seminar. So I have two questions regarding the quality of evidence. So my first question is, how is the quality of evidence assessed in evidence-based practice? And my second question is, what is the significance of risks of bias in evaluating evidence quality? Thank you so much, Prof. Hello, sir. Hello. Hello.
I mean, but yeah, okay, go ahead. If you're still speaking, go ahead.
Okay, sir. My question is,
I've had the question. In fact, I can see the question on the platform, but the last statement you made, that network did not allow me to hear. So you don't have to start from the beginning. Just the last statement you made.
Okay, the last question is, what is the significance of risks of bias in evaluating evidence quality? Thank you.
Wonderful. So now that's the next thing that we are going to look at. Your question, especially the first one. That's the next thing that we are going to look at. How do we know quality of evidence? And when we talk about quality of evidence, there are two perspectives to quality. We are going to discuss the first one now, and then the second one we'll discuss it when we get to the point where we'll discuss a critical appraisal. So what do I mean by the first quality? You have research designs, and I'll give you an example. Case study and RCT. A case study is one that you do on only one subject. There is no way that you can take that result and say that you can generalize it to all the population. It's too small. And that is why you don't generalize case studies. You only understand the concepts before you go into an RCT when you are looking at effectiveness. So meaning RCT has more quality than a case study. So you can take an RCT and apply it on your patients, the results, because it shows that the intervention is effective, and therefore I can apply it on my patients. If a case study shows an intervention is effective, you don't take it and apply it on another patient. You can only apply it on that particular patient that it shows is effective. So that is the first quality, looking at the research design. But the second quality is looking at that particular research design that you said has quality in the earlier perspective. And you are now using critical appraisal measures to see that it doesn't even really have that quality that we said it has. For example, issues of power calculation. They use 10 subjects. It's better than one, but is 10 really enough? Maybe if you do what is called a power calculation, it will give you something higher as a number that should be recruited, maybe 30, 40, or 50. But this one just used 10. So meaning, even though it's an RCT has quality beyond RCT, sorry, beyond, what is it called, case study. But when you now look at critical appraisal rules for an RCT, this particular one doesn't even have the quality that will warrant me to use its results in my own patient. So these are some of the things that we are going to look at in the next stage. And the second question that you have asked is something that is going to go deeper into research methodologies and statistics. And we are going to have a topic. We have a topic, if you look at the hierarchy, sorry, the list of topics that we have, that's going to deal with research methodology and statistics. When we come to do that, you are going to see more details. But as I'm going through the research designs, I'm going to discuss some of those things like statistics. That's going to help us to understand why this one has more quality than the other one. So let's look at that. Okay, I can see another hand. Yes, I can see another hand, but what is it that's showing here? Sign in to see this profile, re-education. Oh, okay, Abdul Samad B. Ahmad. Abdul Samad B. Ahmad.
Thank you, Prof. Sir. Can you hear me?
Yes, I can hear you. Go ahead.
Okay, sir. In terms of quantifying the outcome of a particular evidence, what if the majority of patients we see they used to abscond, so we'll not be able to quantify the outcome? So how can we go about that? Thank you.
Okay, so if patients abscond, now from your prognosis, you're expecting a particular recovery at a particular point in time. And you know you need to give this particular intervention over this particular period for them to get that intervention. I think psychosocial and social constraints that I talked about can help you to be able to understand why patients will abscond. And it takes wisdom and clinical reasoning to be able to influence them to have those sessions that will help them to be able to reach that point that they have that recovery that you have anticipated or you are expecting or that you have planned to have. So it's a complex thing. I wouldn't know why are they absconding. You need to find out why they are absconding. What can you do to be able to help them not to abscond? But researches have been done to show that for patients that have this level of care, this is what recovery you expect. For patients that have this less, this is what we expect. And these researches can be used to explain to them. Look, researchers have shown if you have this number of sessions, you get this level of recovery. If you have this number of sessions, you get this lower level of recovery. What do you want? What really do you want? Won't you go for this higher recovery? Another thing is, there are some conditions that if you don't treat them at the early stage with 10 sessions, if you come at a late stage, even 20 sessions cannot give you this recovery that you'll have within these 10 sessions. So this is what evidence-based practice is all about. And as we said, it gives you reliable information to communicate with your patients and with your colleagues. And this is what is expected of you. You are not just a clinician. You are a teacher. You are an educator. And that is what rehabilitation is all about. It is an active science. You can't just sit down and be like a zombie and just be treating. You are communicating with them. You are teaching them. You are guiding them. You are letting them know. You do your best. And at the end of the day, their consent is what matters. After you have done your own part, which is to communicate with them, to educate them, to give them the evidence, to explain the evidence to them, to share your perspectives with them, and try to influence them and change their own perspectives so that they go along with what the evidence says will give them the best in their recovery. Yes, so thank you. So let's look at the next slides, which is the research evidence hierarchy. Now, this is the research evidence hierarchy. Low in the evidence, so low quality in the evidence is the bottom, which is the expert opinion. Highest quality in the evidence is this, which is clinical practice guidelines. Now, remember those 6 components of patient management that we talked about. And that is why I explained them before coming down here. I'm going to show you some of these research designs that apply across board to all of them. And I will show you those that apply to one or another of those components of patient management that we discussed. Now, expert opinion, as I've said, is at the bottom. An expert opinion can apply to all the 6. Meaning, I have a patient. If you look back from the beginning, everything has a beginning. Someone was saying, who supervised the first PhD? Everyone was thinking, who really supervised the first PhD? The first PhD was not supervised by a PhD holder. I remember there are many physiotherapists on this platform. Professor Hamzat, may his soul rest in peace. Someone said he is the first neurological physiotherapist in academia in Nigeria, in Africa. I think in Africa or West Africa, someone was saying that. So he is the first that got a PhD in neurological physiotherapy. And then someone said, then who trained him? If he's the first, is it from abroad that someone came to train and said, no. There's even Nigerians that trained him. Supervisor, physiology. So what they did was to now invite a neurologist, a medical doctor that's a neurologist, I think, and then he supported the team, something like that. And he got, so what I'm trying to say here is that all the outcome measures that we are using for assessing patients, all the interventions that we are using for assessing patients, there's a time that someone was just seeing patients and he stumbled on something, and at the end of the day, he now said, look, this is working on this patient. So when we say expert opinion is at the bottom level of the hierarchy, someone will think you look down upon that. You don't despise the days of early beginning or whatever it is that they say. Something must have started from somewhere. And believe me, to me, I appreciate that innovation. The innovation to get to the point that it is used in a better way. Because without the foundation, you can't build at all. So let me give an example with some schools of thought. When it comes to expert opinion, you have McKenzie technique for those in orthopedics. McKenzie, he had a patient. The patient came in with severe back pain. He placed the patient in a particular position just to assess the patient or treat the patient, not really with any purpose of placement in that particular position. And the pain of the patient was relieved. And then he just thought, why did the pain got relieved when I put the patient in this particular position? So another patient will come. We'll now put them in that position, and you see that there's a relief. Then he developed that concept, and he built that empire in the area of positioning of patients to relieve pain. It was an expert opinion. And at that time, there was no research, but that's what was being used. Bobert in neuro also made observations about reflexes. When you have a neurological condition that affects the brain, see abnormal reflexes. And if you want to achieve function, you need to suppress those reflexes. These were all expert opinions. They wrote books, textbooks, and that is what takes us to the next category. Based on their expert opinions, they wrote textbooks. But because that expert opinion also that were used to write textbooks, they did not go through because it has not gone through research. And this can apply to all the components of patient management. Think, for example, that came with the idea that you have one arm and another range of motion. Who thought of VAS? This all started with, and then someone took them through research for them now to be established as acceptable means of assessment or acceptable means of treatment or acceptable ways of recognizing the time it takes to achieve a recovery. Someone thought of what symptoms should be put together to be able to have a particular diagnosis. And then they now went through research to look at 100 patients to say out of all these patients, who amongst them have this diagnostic criteria and things like that. So it starts with expert opinion, but expert opinion is at the lowest level of the hierarchy because it has not gone through research to show evidence that it truly works in patient management. Next is textbooks. Now there is a reference. But that reference is not systematic. And because it's not systematic, it is not reliable. Meaning it's just randomly that someone just reads, understand the concepts, and write the textbook. So even though they cite, it does not mean that it is something that the moment you see, you take it and you go apply on your patient. The next is narrative review. Narrative review also applies to all the 6 components of patient management. When you do your master's or your PhD and you have read widely and you understand the concept of what it is you are doing your study on, you can just come and sit down and write to explain the concepts so that people will understand the concepts. And therefore, if you pick a narrative review, so usually a narrative review is one that you just see a write-up with headings. Under each heading, there is explanations of things. So you don't have any structure of introduction, methodology, results, and discussion. No, you just have a paper that is explaining concepts about the area so that people will understand it and appreciate it. So it's also a low-level quality when it comes to evidence. You don't just read a narrative review, you take what they say in it and you go and apply it on your patient. Unless if there is nothing above it, that is when it becomes best available evidence and is better than not using any evidence. But when you have anything above it, you can't use it, you have to use the one that is above. Then the next in the hierarchy is case study. Case study also applies to all the 6 components of patient management. But you are only having one subject or one patient. So you want to see the person that first came up with goniometer. They now want to test if goniometer can really measure the range of motion at the knee. He now gets one patient and he applies a goniometer. And he sees that the result is still giving him something similar. And he now said, hooray, I've now gotten an idea on how to assess the visual analog scale. Maybe he applied it on one patient first. Mackenzie or Bobert would have written a case study on that one subject to say, I'm explaining how it happened. And many of us here, I will open up the discussion at the end of the explanation of this slide. Have you done something clinically that is new and you just observed it on your patient and you see that it worked and then you wrote a case study, maybe even published it? I remember someone in Zaria, a physiotherapist in Zaria. I've read, I think, over 5 case studies that he did. Whenever he makes an observation on his patient, he'll just sit back and he'll write a case study. This is something that you cannot generalize to other patients because one patient is not enough to confirm that the idea works for you now to use it on other patients. And this case study can be for examination, like I've given an example, say goniometer or VAS. It can be on evaluation. maybe the first person that developed that calculation for obesity, when they thought, well, this issue of weight over height squared, would it really work? Maybe they would have applied it to one patient, and then they will now write a case study. The same thing can apply to diagnosis. It can also apply to intervention and also outcome. Can we have the person using Techno case 17? Please, can you mute yourself or let the admin mute the person use? Thank you. So that is a case study. The next is a case series. A case series is an elder brother of case study. In a case study, you have only one patient. In a case series, you can have more than one. 1, 2, or 3. So you can have that. So, but still, you have 3 patients. They are not enough to represent 1,000 patients. They are not enough. It's too small to represent 1,000 patients. Because the idea of having a number of subjects to represent a population is that you consider all variabilities across the patients. So what number will represent 1,000? Say, for example, 50. Will 2 or 3 represent 100? Not likely. If you're having 1 million, will 50 represent 1 million? Possibly not. You'll have to increase the number for you to have good representation of the whole population. So this is why case studies and case series are weak. They are low in quality as research designs. So you can have results from a case study or case series, and you'll apply it on your patient, and then you'll say that my practice is evidence-based. No, it's not evidence-based. You have used evidence. You have used best available evidence for your patient, but your practice is not evidence-based. So from expert opinion, up to case series, they are considered as low quality research, and they can apply to the 6 components of patient management. Now, from where do we now begin to have high quality research? We begin to have high quality research from case control studies. But from case control studies, we also begin to have research designs relevant to one or more of the components of patient management that we have discussed. And I'm going to explain that further. Remember when I was giving examples about evaluation, I talked about risk factors. And I said, if you look at the age of the patient, higher age, usually at risk of having cardiovascular or neurological conditions. Gender, female, more at risk of having cardiovascular. So for the age, lower age, more at risk of having musculoskeletal. Males are more at risk of having musculoskeletal. Smoking. Please, can we, admin? Please, Brendan Ikechukwu. Please, admin, help mute people as they unmute. Now, what am I saying here? There are risk factors for diseases or conditions. How do we know something is a risk factor? For example, smoking or obesity. Obesity is a risk factor. Smoking is a risk factor. Alcohol intake is a risk factor. And at the level of risk factor, it helps us to be able to narrow down. Usually you suspect a system because risk factors, they don't help you to choose one condition and say it is this condition that the patient has. Because risk factors can be risk factors of a number of conditions under a particular system of the body. So you are now picking something to say, because who knew that smoking was a risk of having cardiovascular or pulmonary diseases? Who knew? Someone at some point did a research. It was a case control study that they did. And how do you do that? It can either be prospective or retrospective. But I'm not going to go into the details of the design. I'm not going to go into the details of the statistics. I'm just going to explain the concept. So that as a clinician, if you want to know if something is a risk for a particular disease, when you do a search and you read, you can understand. Because when you get the paper and it says a case study, will you apply on your patient? No, you won't. But when you say it's a case control study, you know it's a high quality research. And then you will understand what a case control study is and how you can extract information from it and how you can use it in asking your patients question whether they have that risk factor in that paper in them for you to begin to do your evaluation of saying that you want to narrow down to a particular system out of the systems that you suspect the patient will be suffering from. So in case control study, you have, say, smoking. So you now recruit smokers. You recruit your control, which is non-smokers, those that don't smoke. So if you are going forward, which is prospective, you now look at, so this is why it's called case control. The case are the smokers, the control are those that don't smoke. And when you follow them up over time, you now assess to see who amongst them develop the condition that you want to see whether smoking is a risk to. And then among the control, who amongst them develop the condition? Meaning you are going to have 4 categories. You will have among smokers, how many develop the condition? Among smokers, how many do not develop the condition? Among non-smokers, how many develop the condition? Among non-smokers, how many develop the condition? So you have 4 categories. Is that, let's say, for example, among smokers, there are 100 of them. 80 develop the condition, 20 do not develop the condition. Out of those that don't smoke, let's say 40 develop the condition, 60 do not develop the
Sorry, I think network, we have network issues. We will soon be back, please.
Apology, I was kicked out by network. Please, can someone let me know at what point you stopped sharing me?
I think around comparing smokers, a little bit about comparing smokers and in-case control studies. And
Okay, thank you. So I'll continue from there.
I think you are muted, sir.
No, sorry, I called someone to come with another service provider. So he's here. Just want to compare so that before he leaves, disconnect me. Give me a minute, please, just to talk to him. Thank you very much. I'm just trying to get an alternative. I have MTN and Airtel, so just want to get 9Mobile in case I have another network disruption. Yes, so as I was explaining, case control study is to establish if a particular factor is a risk factor for a particular condition. And I was given an example with the issue of smoking. So smoking puts someone at risk of having, say, cardiovascular diseases or pulmonary diseases. So what you do is to pick that condition, you now pick the factor, and then you select a case, which is those that are having that factor. So that's, for example, smoking, and those that are not having it are, for example, people that are not smoking. You now follow them up.
Sorry, the network kicks him out again. I know he will soon come back and join again. Just exercise some patience, please.
Apology once more. So I hope this time around is sorted fully. Yes, so the bottom line here is, if you want to know whether a particular factor is a risk factor for a particular condition, when you search, you need to know that the paper is a case control study. That's the lowest that you can accept for that. It's a case control study. If you see a case series, don't accept it. If you see a case study, no. Until you see a case study, control study, that's where it starts. Going forward, that's high quality research for risk factors. Now, for symptoms and signs of diseases, I'm going to rush through so that we can be able to go and do the main thing. This one is just to explain so that when we do the search and we get the evidence, to understand what the evidence is all about. What even research design is in that research? Is it one that we can accept as high quality or low quality? So if it's a case control study for risk factors, so you want to know, is smoking a risk factor for a disease? Is obesity a risk factor? Is alcohol intake a risk factor? And many other risk factors, age, gender, and what have you. Are there risk factors for diseases? How do we do our evaluation? It is through this information. We confirm through evidence that the factors that we are assessing in patients puts them as risk of such conditions, that we now go ahead and evaluate and say that, yes, we suspect that they may have such a condition. Now, you'll see a lot of the relevance of this issue of risk factors and case control studies when we come to discuss systems review. And systems review is in the calendar. We are going to see how we suspect a medical condition that we refer to physicians. So how do we know that there is suspicion of that particular medical condition? It is a lot of it depends on the risk factors that are there, especially when we are looking at what is called a yellow flag. When you are looking at a red flag, it is a combination of risk factors and other symptoms and signs that gives a red flag that confirms that there is need for referral. So it's very important for us to understand these concepts before we even get to that particular workshop that we're going to have later. So case control study. Now, when you are looking at symptoms and signs, you want to assess and see if there is a presence of a symptom or a sign in a patient. Pain, range of motion, many other symptoms and signs. You want to assess if they are present in a patient. And you have developed an outcome assessment tool, an outcome measure, to assess the presence of a symptom or a sign in a patient. You can see all these things that we are discussing are under examination. They are under examination. And therefore, case control study applies only to risk factors, while cross-sectional study applies to symptoms and signs assessment. So the tool that we have developed, is it valid and reliable for use in assessing the presence of a particular symptom or a sign? Is it valid and reliable? So for example, visual analog scale, or the goniometer, or whatever assessment tool that we have. Validity is asking whether that tool is assessing what you want it to assess. You can't take visual analog scale with patient that has pain in the knee, and from 0 to 10, it says 5, and you say that, well, this shows that they have 80 degrees of range in the knee. That doesn't measure range of motion. What does it measure? It measures pain. So validity is about the outcome measure assessing what it is expected to measure. So let's assume there is something existing already. You want to measure pain. VAS is there. It has been shown to measure pain. You're now using your innovation. You come with a new assessment for measuring pain. If you apply it in patients, it's not evidence-based. You now want to put it through research to show that there is evidence for its use in assessing pain. Let's assume we call it Penn scale, just Penn scale. This is VAS, visual analog scale. This is a new one I call Penn scale. And I want to assess if this Penn scale is valid for use in assessing pain in patients. So what do? I use a cross-sectional study. A cross-sectional study is a study in which you collect data at one point in time. So when you collect the data now, you don't wait for some time to come back and collect the data again. This is what is called a cross-sectional study. And what do? I now have patients that have pain. I assess them using visual analog scale. I give them visual analog scale. I say, okay, mark where your pain is. They mark, I check the record. Then I will use the Penn scale to assess them. And when I assess them, I will keep the record. So meaning I'm going to have a column with their ID or name, a column with their data for visual analog scale, and a column for their data with the new one, which is the Penn scale. Then I will use a correlation analysis. As I've said, I'm not going to dwell on the methodology and the statistics. I'm just explain what the research design is all about and how it relates to the components of patient management that we're talking about. So a cross-sectional study is one in which we are now trying to establish the validity of that outcome measure, whether it is assessing pain or it is not assessing pain. What is the concept? Since VAS is already accepted, if this Penn scale is also measuring pain, then it must correlate with the results of the VAS. Meaning if VAS shows there is a higher level in pain in this patient, this Penn scale must also show there is a higher level in pain. If in another patient, the VAS shows is low level of pain, this new outcome also must show low level of pain. But if VAS is showing the patient has higher level of pain, and this pain scale is showing lower level, then it means it's not measuring pain because there is no correlation between it and the one that has been established that it does that. So this is what cross-sectional study is all about. So I now want to assess a patient using a particular outcome measure, but I'm not sure if it is valid and reliable. At least let's use validity. Because of time, I will not go into reliability. So I want to confirm, is there any evidence that this outcome measure that I'm going to use is acceptable, is valid for assessment of that symptom or sign that I want to assess in that patient? So I will use a cross-sectional study. Remember case control study for risk factors, cross-sectional study for symptoms and signs of diseases. Then cohort study. Cohort study is sometimes it's called longitudinal study. Remember in cross-sectional study, I said when you measure now, you don't wait until another time to measure again. But in cohort study, you measure now, and then after some time, you measure again. And an example of component of patient management that you use cohort study for is prognosis. Prognosis. So you are not given any intervention. Because for interventions, when you measure, you give the intervention, then you measure again. And that is where you now look at the pre and post. You compare them after giving the intervention to see if the intervention is effective. But in a cohort study or longitudinal study, you are not giving any intervention. It's only time that is in between the two assessments. And in prognosis, remember, we said it's about recovery, some factors, and the time it takes for the recovery to be seen. Whether there is intervention or not, how long does it take people to recover over a period? So for example, in stroke, that you can have spontaneous recovery without any intervention. patients have gone back to where they live, but they still recover to some extent. That period, it takes them to have that recovery. We can be able to assess that using a cohort study or longitudinal study. So you will get patients. You will assess their severity. You assess their age. You say, these people that have this level of severity and this age, let me follow them up and see how long does it take them to be able to sit without support. That is my recovery that I'm expecting, the goal. How long does it take for them to get there? It is cohort study that shows that. And therefore, if you want to see prognosis, one of the studies or the research designs that you can use is a cohort study. And a cohort study is a high quality research, at least for prognosis. It can be used for other components of patient management like examination, but I'm not going to go into that. Just want to simplify it so that we'll understand all these research designs. And when we are looking for papers, if it is about prognosis, if I see a case series, I will not accept it. If I see a case study, I will not accept it. If I see a textbook, I will not accept it to give to my patient. I'm looking for a cohort study. When I see the paper says cohort study, I say, yes, this is the paper I'm looking for. That is the one that is high quality research. And therefore, let me get the results, learn how to apply, let me apply it to my patient. The next is randomized controlled trials. So this is for intervention. Remember, we talked about case control studies for risk factors, cross-sectional studies for symptoms and signs. All these are under examination. Cohort studies for prognosis. For diagnosis, it could be a cross-sectional study. But for intervention, it's always going to be a randomized controlled trial. Randomized controlled trials. So Bober technique, it was an expert opinion. Now a researcher says, look, I'm a disciple of Bobert. All this one that they are talking about evidence-based practice, they are looking down upon the idea of my mentor. Let me put them to shame. Let me do a research, an RCT, to confirm that the Bobert technique is effective in treating patients that have cerebral palsy or that have stroke. The disciple of Mackenzie will say, let me pick these movement techniques or positioning techniques. Let me put it through a randomized control trial. Let me put to shame all those people that are saying my mentor's idea is at a low level of the hierarchy of evidence, it's a low quality. Let me do a randomized control trials. And that is how all those techniques were shown now to be effective. It is the disciples of those people that had the expert opinion that put it through research. What do? You have people that have that condition. So low back pain or stroke or cerebral palsy. You will have your inclusion-exclusion criteria. I will not go into the details, even though I'm going to talk about inclusion-exclusion criteria at a later time when we come to look at steps of evidence-based practice. But now I just want to show the concept of RCT. When you have people that have that condition, say low back pain, there are 100 of them. But you want to put one group to be an experimental group and the other group to be a control. So out of the 100, you will not give them numbers. Or what you do, you put numbers, 100 numbers into a hat. That's the randomization. You pick one number and you give it to the first person. If he opens it, it says 1. So 1 to 100, you say all even numbers will go to experimental group. All odd numbers will go to control. You now put them randomly. Why are you randomizing? So that there won't be bias. If you don't randomize, you put people into groups without randomizing. it's very possible that they will have some characteristics that makes them to get better in that group. And therefore, you can attribute whatever result to the intervention of interest. So when you put them in experimental group and in control group, the experimental group, you will not give them that intervention. For example, let's say Bober technique or Mackenzie technique, or say the use of ice. You want to see if ice can be used in relief of pain, or infrared, or whatever intervention that we are talking about, whether it's a drug, can use a drug. Then the control group, don't give them anything. But be careful, I'm going to come back. There are some instances that you don't leave control without giving them anything. I will explain how to do that, but I just want to take it in the simplest term. You give the experimental group the intervention. The control group, don't give them anything. So before you start giving them anything, you assess that symptom you want to treat. Let's say it's pain. You want to treat pain. You assess pain before you give the intervention. Let's say it's eyes. You want to assess whether eyes is effective in treating pain. Before you give the eyes, you assess the level of pain, say using visual analog scale. In the control group, you assess the pain. For the control group, you now give them eyes, say for 2 weeks or 3 weeks. The control group, you don't give them anything. Then at the end of the whole intervention, you now assess again the level of pain in the experimental group, and you assess the level of pain in the control group. You now use a statistical analysis. Remember, in a case control study, I said chi-square. In cross-sectional study, for validity, I said correlation analysis. But in randomized control trial, you use a t-test because you have 2 groups. You use a t-test. It is the t-test that later will now tell you whether the reduction in pain is more significant in the experimental group. Because of the fact that you have randomized, you have shared all characteristics of the patients in the 2 groups. And therefore, if you have an improvement more in the experimental group, you can only attribute it to the intervention that you have given there. And that is what shows evidence that, yes, that intervention really works in relieving the pain of patients. And because of the fact that you recruited enough number in the sample to represent the total population of people that have pain in that condition, you can have some level of certainty that, yes, this intervention really works. And therefore, if you get a paper that is a randomized control trial, and it says at the end, the conclusion, that eyes therapy is effective in reducing pain in patients that have new osteoarthritis. If patients have your patient has osteoarthritis, you can pick eyes and you can apply it in that patient. This is what evidence-based practice is all about. So if I'm searching to see the effectiveness of a particular intervention, if I see a case study, will I look at it and apply it on my patient? No. If I see a case series, will I apply it on my patient? No. Will I be looking for a case control study? No. Will I be looking for cross-sectional? No. Until I see an RCT, that the paper is a randomized control trial, that's when I say, yes, this is the paper I'm looking for. And that is when I will even go and begin to read about the paper so that I can extract what they did to the patient and then come and do it on my own patient. Next to reach is systematic review. Systematic review is higher because, let me pick randomized control trial. Sometimes you can have one study, use 5 subjects, and they will say not effective. The intervention is not effective. You'll have another one using 10, will say not effective. But another one will use 20 and will say effective. And you'll be confused. Which one then do I use on my patient? This one say not effective. This one say effective. Which one do I use? In that situation, you now do a systematic review, or you look for a systematic review. A systematic review analyze these randomized control trials, separate ones, analyze them. Maybe it will say that, look, do you know why these two said it's not effective? Because they use smaller number. 5 and 10, they are small, but 20 is big. That 20, because it's bigger, that is why it shows that it is effective. These ones, drop them. Use this one. That is an analysis, but it is a subjective analysis. Then a meta-analysis is one that goes beyond subjective assessment. What a meta-analysis does, you go to that one with 5, you take the raw data. I hope I'm still on. Okay,
Yes, you are, sir.
Okay, wonderful, thank you. You now go to the one with 10, you take the raw data. Is it not mean and standard deviation that the papers report? There is visual analog scale, the score. You take its mean for across the patients in that group and the control. You take the standard deviation. There are other statistics. For example, if it's intervention, they say effect size. Whatever it is, let's not go into that. You go back and take the raw data, whether it's mean and standard deviation, whether it is effect size, or whatever it is. The question that Nasr asked, you pick that method of analysis from the different studies, whatever it is that you used. You now come and you run another analysis to merge the one with 5, the one with 10, the one with 20. Is it not the small number that is giving problem? Then bring 20, add to 10, add to 5. Instead of having 20, you are now going to have 35. You now run an analysis. At the end of the day, whatever result it gives you, if it says if it's effective, you just take it as effective. That is what a meta-analysis does. It is superior to systematic review because systematic review is looking at subjective assessment, while meta-analysis is bringing the data, raw data of all the studies, running another analysis so that it gives you something superior. And you can do a systematic review for a cross-sectional study, meaning one study says visual analog scale is valid. Another study says it's not valid. So all the studies are supporting this side or this side, and you are confused. You just do a systematic review. That systematic review will subjectively tell you which side is correct. Or you can go ahead and do a meta-analysis. The result, is it not an R value, a correlational value? You take that R value of this study, take other R value of this study, take that R value of this study, then run another analysis on all of them. The result will be superior to each individual study that reported what they reported. So that's a meta-analysis. Then a clinical practice guideline is the highest, because the clinical practice guideline considers all these studies, the meta-analysis, the systematic review, the randomized control trial, and it is not done just by a group of researchers. It is groups of experts, a group of experts selected from across the world within the specialty of interest. So they will call this person, he's an expert in the area. This one is an expert in the area. This one is an expert in the area. You now set a criteria for accepting the meta-analysis, systematic review, randomized control trial, and all others. Even the randomized control trial, as good as it is, we have a criteria to even choose whether to add it or not. And at what level do we even place it? Is it at level evidence A, B, C, or D? At the end of the day, they now have consensus, and they come up with something that everyone can use for treatment of patients. It is the highest level in the hierarchy. So clinical practice guidelines, meta-analysis, systematic reviews can apply to all. Expert opinion, textbooks, narrative reviews, case series, case studies can apply to all components of patient management. But this one that are in the middle, case control studies will apply to only risk factors. Cross-sectional study will apply mainly to assessment of symptoms and signs. Cohort study will apply mainly to prognosis, while randomized control trial will apply only to interventions. So this is the research evidence pyramid. We have, as part of the series, research methodology and statistics, and that is where we are going to deal more on how to do these researches using these different research designs. The relevance of explaining this is not for us to know how to carry out research using these research designs, but the relevance is for us to be able to know what evidence to apply to which patient for what component of patient management. So if I want to assess my patient risk factor, I will use a case control study. If I want to know if the outcome measure I want to use to assess the symptom and signs of my patient, I will be looking for a cross-sectional study. If I want to know what is the prognosis of my patient, I will be looking for a cohort study. If I want to know what intervention to apply to my patient, I will be looking for a randomized control trial. And for all this, if they exist, and systematic review or meta-analysis or clinical practice guidelines exist, I will not use the randomized control trial, I will use the clinical practice guideline because it is superior to one randomized control trial, because it is now bringing together all the RCTs, analyzing them, and giving expert opinion and consensus before presenting the result for use by clinicians. So what I'm talking about right now, even if because of my bias in academia, I present it in an academic manner, I'm telling you that this is for clinicians. Because whatever academics do is supposed to translate into practice. So if you are a clinician here, I'm speaking to you because evidence-based practice is about the practice. It's not about the academics. So let me stop here and ask if there are questions. And most importantly, I want you to consider what I asked earlier about your experiences with cases that you have seen, that possibly you have written a case study or a case series. But overall, do you have any questions or comments on this research evidence pyramid? Thank you. Yes. So the name is in Arabic, Allahu Muhammad. Whoever is using that device, you can unmute and speak.
Good afternoon, sir.
Yes, afternoon.
So, my question is regarding the last one, which is the expert opinion. I think we were once told that is the second to the last. That textbook is the last, and I think during our undergraduate, that's what you taught us. So, and now I see the arrangement has changed. I don't know why. So likewise, I think that's my question.
Okay, thank you. Actually, if I was one that taught you that textbook is last, then maybe I was wrong, or possibly you are the one that mistook what I presented, because actually expert opinion comes before anything is written. Remember the explanations that I gave to you earlier, that someone will be seeing a patient and he will just develop something. And then after developing that thing, he now begins to explain it in a textbook. Now, in the explanation in the textbook, you are now going to have more than, just the opinion of the expert. There are going to be explanations around the opinion of the expert. Usually we'll draw on what is called theoretical framework or conceptual framework, because a textbook is hardly written on just an opinion and you keep repeating the opinion. Usually you draw on concepts and theories and you now explain that clinical opinion, and that is why textbook will come at a higher level than the expert opinion. So if I taught you that textbook is the lowest, then I was wrong at that time, but possibly it might be that you got me wrong. So anything is possible, but if you look at evidence-based practice documents, you'll see that expert opinion comes before our textbooks. But whatever it is, all of them are at the lower level of the hierarchy. Lower level of the hierarchy, the two of them. Thank you. Yes, M.A. Akib. Go ahead on mute.
Good afternoon, sir.
Afternoon.
Thank you for the presentation. Please, sir, I need more light on the meta-analysis.
Okay, you need more light on meta-analysis.
Yes, sir.
Okay.
Thank you.
Okay, so in meta-analysis, remember we are talking of a study that synthesizes other studies in the lower hierarchy. I gave an example with RCT. So you have a randomized control trial that the researchers in the conclusion said ICE therapy. I've been given an example with ICE therapy. Let me change. The question has been forwarded. We'll look at that. Don't worry, I've read it. T-test, I will respond to that. But this issue of meta-analysis. Now you have an intervention that one study says, you know, it's possible. We see that very often. You get 3, 4, 5 RCTs and all of them having different conclusions. And you'll be wondering, it is the same intervention. Why will this study tell me that it is effective and this study will tell me it's not effective? Which one do I now apply on my patient? To the clinician, it's confusing. Which one do you want me to use? Should I apply it or should I not? Because this one says it's effective, this one says it's not effective. So what a meta-analysis does, when we come to look at critical appraisal, you are going to see the issue of power calculation. Power calculation is the calculation that you do to know what is exactly the number of participants you should use in the study so that if there is effectiveness, it will show that there is effectiveness. There is what is called type 1 and type 2 error in research, meaning the effectiveness is there, but the study will show it's not there. Or the other way around, it is not there, and the study will show that it is there. And this is misleading. So if one study shows effectiveness is not there, and another study shows it is there, how do I really know whether that intervention is really effective? Then you now come and do a meta-analysis. So what the meta-analysis will do is to go back to the raw data collected on each of the different studies. It will now pool the raw data. It will then run another analysis. Now, instead of saying this one used 10, this one used 20, let's have another study that will do 100. Why waste time and resources? You have studies, this one 20, this one 10, this one 15. Why don't you just pool the primary data and now run another analysis on it without the need of going back to conduct a separate study? So this is what meta-analysis does. And as I've said, we have this workshop. If you look at that timeline, Dr. Jibril, are you there? Dr. Jibril Samani. Yes. Do we have any workshop on systematic review and meta-analysis in the series?
Even two modules.
Wonderful. So please, Akib, just get that, what is it called? The schedule, look at the dates and try to attend. Because I know the person that's going to facilitate is someone that's very, very good in that area. I know he knows that more than myself, and that's why he was chosen to present. He might, the
Okay,
other
sir.
time he did it, I think he did it in an advanced way. And I think we are going to talk to him to make it much more simpler so that people that have beginners can be able to understand.
I'll join him even this time. We'll do together.
Oh, wonderful, wonderful. That's great. So I can't really give you much more because of the timing of this workshop. Now, this question on the platform that says, if t-test is appropriate for RCT, what other tests are suitable for cross-sectional study and those studies below it? For cross-sectional study, remember I told you, I said if it is for correlation, because the cross-sectional study, it will all depend on what you want to achieve. I said you can use cross-sectional study to establish the validity of an outcome measure or an assessment tool. So I gave an example with pen scales, 2 pen scales, visual analog scale and a pen scale, a new pen scale that has been developed. And what will be the data that you will get? From 0 to 10, you select a number on the visual analog scale, and it gives you a number. Another patient, it gives a number. In another patient, it gives a number. You now put them into a column. You now ask the statistical analysis to correlate the column of visual analog scale and that of the pen scale. It's a correlation analysis. Dr. Drew Samani, can you give 2 examples of those correlation analysis?
Okay, Spearman.
Spearman's rank correlation coefficient and Pearson's. Exactly. I forgot the name. So Pearson's and Spearman rank correlation coefficient. So these are analysis that you use for cross-sectional study that is a correlational study. So Spearman's and Pearson's. And I don't want to go into statistics more, but the type of data might also determine what type of analysis you can use. For the t-test that you are talking about, it's either a t-test. If you have more than 2 groups, it might be an ANOVA, and so on and so forth. So I'm not going to give a lot of information about statistics. As I've said, there is a statistics class in the series. So if you want to dwell on statistics, I think that would be the best place to go to. So, but for example, if you are using, what other ones did I mention? Yes, the case control study. I think I mentioned chi-square. It's CHI, chi-square analysis. It's looking at 4 different categories. That's why they call the table 4x4 table that you use to run the chi-square analysis. So you are looking at the risk factor. So these people smoke, this one don't smoke. Under those who smoke, there are people that develop the condition, people that don't develop. You have 2 categories. Under people that don't smoke, there are people that develop it, people that don't develop it. You have another 2 columns. And therefore, you have 4 cells, 4x4. You run a chi-square analysis. And at the end of the day, it will tell you whether that factor is a risk factor or it is not a risk factor. Please, I'm not on the platform where you make information available to physiotherapists. Please add me, thanks. So if in as much as you are on the WhatsApp group for this particular workshop, Hafiz is going to send the schedule so that you'll have access to it. But if you are not there, then just let them know so that you'll be added on that group. I think Hafiz is doing very well in sharing this information across all the platforms for all the workshops that we have had in the past. Yes, thank you so much. I'm happy that there are questions, there are comments. It's an encouragement that at least we are together and we are moving at the same pace. Thank you so much to everyone. Now, do you want us to take the next slides or do you want us to take a break before we do that?
Let's move on, sir.
I think we go for break.
Okay. So do we take the main break now or just a short break of 10 minutes and come back before we take the main break? What do we prefer?
Prof, so I think we can just take a leg stretch, maybe 10 minutes thereabout, and then we'll
Okay. And then come back and continue. Okay, so let's take 10 minutes break and come back. And then after an hour, we'll now take the longer break. Okay, when we come back, we'll discuss case series and systematic reviews. But let's go on a 10-minute break. That means we are coming back by 12:52. So 12:52. Thank you very much. Okay, I hope we're back. Thank you so much. We are going to continue. Yes. Yes, Mukhtar. Mukhtar, Lawan, I think you were saying something.
No, I just welcome you back, sir.
Okay, thank you very much. Thanks a lot. Okay, I think there was a question earlier about the issue of case series and systematic review. So case series, as I said, we have case study. So in a case study, you have only one patient. And in that one patient, you apply the intervention, if it is an intervention, to see whether it's effective in treating that patient. Or you want to use an outcome tool or outcome assessment, outcome measure to assess a symptom or sign in that particular patient. So just the fact that you see that that tool can be used for assessing that patient, or that the intervention is effective on that patient, you can't generalize. You can't take the result of that patient and say that because it works, let me apply on my own patient. You can't generalize. The result can only be applied to that patient. Case series is similar to case study. Instead of one patient in the study, you are recruiting 2 or 3 patients. So it's a case series. But in this kind of studies, you don't even run statistical analysis. The result, you present it descriptively, just to say that, well, we have seen an improvement in this patient, or that this tool is simple to use in patients like this, and therefore the result is limited only to those patients in the study. You can't generalize it to other patients outside the study. But for a systematic review, the last explanations I made about meta-analysis is similar. When you have studies conflicting, some said effective, some said not effective, you pull them together. If you analyze them subjectively, it's a systematic review. If you analyze them objectively, it's a meta-analysis. Now, what do we mean by subjective analysis? When we come to do critical appraisal, you'll see what I mean. The critical appraisal tools ask questions about methodology of the study. For example, it will ask, this randomized control trial, did they really randomize, or did they just call it RCT? You now look at the process. How did they do randomization? And you realize that it wasn't even the randomization. The researcher was just placing patients as they wish into the groups. Then you now take note of that. That's a limitation of that study. You now ask, was there really a control, or was it not a control? Yes or no? Did they do power calculation to calculate the appropriate number of participants to recruit in the study? Is it yes or no? There is something called blinding. When you assess the patients, you should not be the one to give them the intervention because you'll be biased. So if you assess the patient and you see that the experimental group is going to get an intervention, the control group is not going to get anything, at the end of the day, after giving them the intervention, when you come back to reassess, the outcome measure you are using, you'll try to give them a higher score because you are expecting them to get better. And therefore, naturally, you want them to get a higher score. That is biased. And that is what is called blinding. Meaning, if I'm assessing the patients, I should not be the one to give them the intervention. So all these are part of what is called a critical appraisal. And if you do all those critical appraisals, that is what a systematic review uses. Then they will say, oh, look, this study that says it's not effective, from this critical appraisal, they have scored no to many of these items that we have looked at. They didn't do randomization. They didn't even have a control. Oh, see, this is a rubbish paper. There is no blinding. Oh, this is a rubbish paper. But the ones that says it's effective, they did randomization, they did blinding, they did power calculation, they did, this is a good one. So meaning the ones that reported effective are the good ones. And therefore, we recommend that you use their result. This is a subjective analysis using what is called a critical appraisal. And I'm going to show you the critical appraisal tools and how you can use them to assess which papers to use and which ones not to use. And that's exactly what they do in a systematic review to advise clinicians on what papers to use for their clinic and which ones not to use. So I hope that is clear. So can we continue? Let's continue. Now, what we have looked at is number one of the components of evidence-based practice. We say the evidence itself, high quality research. I believe we now understand what high quality research is and what research designs are accepted as high quality research. But remember we said, if you get the paper, you must learn how to apply it in your patient. And your level of expertise is what determines to what extent your skill in applying that in your patient is. So I'm just going to quickly go through the levels of professional knowledge development. Pre-service is the lowest level. So someone that is in school, you're an undergraduate, possibly even at the level of internship, because it's also pre-service. You have not become independent in serving. So pre-service, we all know, is in school. Someone begins to become aware of their own beliefs. So there are schools of thoughts. Which one do you believe is better? It's a belief. Learns initial strategies for questioning those beliefs. So there is evidence. Do I believe? Because up till now, I remember arguing with someone about the issue of using backslap. That is why I always give an example with that. The person at that level of pre-service was really seeing that because all the elderly people are using it. Why will you just come one day and just tell me that it is not acceptable to use backslap to stand our patients with stroke? We kept arguing. And recently someone just came up to me and said, look, it's not because we want the brain to learn how to use it. This is the justification for using it. So all this are beliefs and justifications and things like that. At the pre-service level, you begin to have those beliefs, you begin to question them, you learn how to use available evidence to construct reasoning strategy and decision-making guide. Those at that level, you begin to learn how to use clinical reasoning. Remember, we are going to have critical reasoning. I think it's next week. So we'll discuss more on this part. Then there is novice. So the pre-service, you are in school. And clinical years in school, internship is all considered as pre-service. Then novice, generalize ideas, determine effective and ineffective methods. Because you now have the chance to read the papers, extract it, apply it, and see whether it works or it doesn't work. Then maybe later you realize you didn't even apply it well. That is why it didn't work. It's not that it's not effective. So you'll now ask a question. Sir, I read this paper. It says this intervention is effective. But I'm applying it on the patient, and the patient is not getting better. What's happening? They say, no. The paper you read, the patient did not have cognitive problem. But in your own case, the patient has cognitive problem. Oh, that's why it didn't work. You are a novice. Someone there is guiding you using clinical reasoning. A novice is usually within 5 years of practice. But if you don't advance yourself, you don't study, you don't do CPD, you don't read papers, believe me, you can spend 10 to 15 years in the level of novice. Because there are some people that can be experts in doing the wrong thing. You are an expert, but your expertise is in applying the wrong techniques to patients. So just be careful. It's not everyone that goes beyond the novice level within 5 years. There are many people that can get to 10, 15 years, they are still novice. Especially those that will go to office and sit down from morning till evening asking interns to go and see patients. They are even more likely to stay in this novice level for 10 to 15 years. It is in this level that people learn how others apply knowledge. try ideas and evaluate the effectiveness in individual situations. That's the novice level. Experience level, they establish methods of evaluating effectiveness. So they are beginning to have that clinical reasoning that they will say is because of factor A, B, and C that this patient gets better more than this patient that has. So looking at that prognostic things, you are beginning to develop that clinical prediction rule methods to be able to say that in this patient, he'll get better more than this. So when they come, you are an experienced person. Say these two patients, do you know that this patient will get better more than this one? And you just leave. And after 2 weeks, the novice will come to you and say, Oga is a magician. How do you know this patient will get better than this? They say, no, from the assessment you did, this patient had this score in this outcome measure, this patient has this score. From this score, it shows it will take longer than this one. You didn't know. He's using indices. That's because he's at the experienced level. Hypothesizes successful therapeutic techniques, similar to what I've just explained. Usually it's within the second decade, so after 10 years. But there is a risk of abandoning evidence for tradition. You don't use evidence 10, 20 years, you will be fighting with younger ones coming with evidence. What are you going to tell us? For 20 years, I've been applying this and it has been working. Just one day you come and talk about evidence to us. I beg, leave. So there is that risk. And therefore, you don't want to get to that 10 to 20 years without evidence-based practice. You want to continue to search. Let it not be your interns that will come and be telling you things about evidence. You should be the ones telling them you are not using the evidence. Then professional knowledge development. Expert professional period. They don't just do the thing. They guide and teach others to do it. They critique the work of others. They share knowledge. You see experts after second decade of practice, 20 years and above. But with professional advancement, you can see that very much earlier. So for example, you do residency program, you have a fellowship program, and all that. You can have this happening much faster and earlier. That's the second component of patient management. Practice-generated knowledge. The third is patient preference. How do you ensure that your patients are carried along? You need to explain to them using the evidence, the situation of things, and your own perspective. You need to seek for their consent, and you need to make them part of the team. You don't own the patient. It's because of the patient that we are here. So let the patient be part of the team. When we say multidisciplinary team, the patient is a member of the team. The caregiver is a member of the team. The health professional is a member of the team. Everyone is a member of the team. Now, let me give you examples of my encounter. Many of you here would have heard that because I say it in every workshop that we do on evidence-based practice. Looking at those three components: high-quality research, practice-generated knowledge, patient preference and perspectives. So you have the evidence. You will apply it. If you don't consider practice-generated knowledge and patient preference, it's not evidence-based practice. You must have all the three. Now, under practice-generated knowledge, I always give an example with trunk impairment scale. Trunk impairment scale is used to assess trunk impairment in patients with stroke. My supervisor developed it. Professor Geert Verheyden is from Belgium. He was in the UK, Southampton University. He was my second supervisor. He developed it in his PhD. He published it. People are using it. When I met him, I got to understand, because I had interest in balance. I did a systematic review, and it was one of the outcome measures that was included in the systematic review. I understood it. I knew how to use it theoretically. I've discussed it with the owner, the inventor, the person that developed it. And when I came back home, in Aminu Kano Teaching Hospital, I started a team that we wanted to establish a stroke unit. The hospital approved it. I was now trying to train people on how to use outcome measures in assessment as part of the stroke unit that we developed. So the expert that I was, I gathered my colleagues, said, where's the subject? The subject was there. We got to the point that in one item, it says, rotate the lower trunk. And I asked the subject, rotate your lower trunk. And the subject didn't know what to do. And I didn't know what to tell the patient, how to instruct the patient to rotate the lower trunk. I got confused, and it showed. And they realized that. But as I told you earlier, I just returned from UK before, so for me, it's easy to say I don't know. And therefore, I told them, wow, I thought I knew this thing, but I never practiced it. Please give me some time. Let me go back and practice it so that I will come back and then I will teach you how to do it. I went away, and I later realized that when a patient is sitting, if you move one knee forward and one knee backward, you rotate the lower trunk. And therefore, that idea came to me while I was trying to practice, and I read more, and I realized practically this is what you do to rotate the lower trunk. Then the second session we had, I was more confident, and I asked the patient to do it, and they did it. That was when it dawned on me. It's one thing to have evidence, but it's another to put the evidence into practice. So having the information is not enough. You need to learn how to apply the information. And this is where practice-generated knowledge comes into play. For patient preference, it was also another experience for me, very interesting experience for me. Mirrotherapy. I taught a patient how to use mirrotherapy, patient that had stroke. I said, this is the mirror. I want you to put your unaffected hand facing the mirror. And I want you to move, make a fist and open. But look into the mirror and assume the hand in the mirror is your affected hand. So the affected hand is on this side. The mirror is facing the unaffected hand. And he did the movement 150 times. And he was reluctantly looking into the mirror. I didn't know why. I kept asking him, if you don't look into the mirror, nothing is going to happen. He wasn't interested. When they were going home, I said, the relative, get a mirror, fix it on a table, ask Baba to move the unaffected hand and look into the mirror, assume the hand in the reflection is the affected side. They came back. Did Baba do it? The son told me Baba didn't do it. I said, why? He said, Baba said I was crazy. I said, sorry, what do you mean I'm crazy? He said, Baba said, how would I come to you with my affected side and you now ask me to do 150 movement with my unaffected side? What's the problem with this hand? Why will you ask me to do hand exercise for 1 hour? That's crazy. And that's when I knew all the evidence that I've read was not useful at all. Because I did not explain the concept to the patient. I did not consider his own perspective. I did not really explain to him my own perspective. And therefore, he never did. Why wondering? Now, exercise. Of course,
Very funny indeed.
Please mute yourself. So yes, I just gave him exercise. So that was when I realized the concept of patient preference is very, very important. And the next time the patient came, I sat him down and I said, this problem you have in your hand and leg, it's in your brain. This side of the brain is the one that controls movement of this hand. But on the way, there is a blockage. That information that will instruct the hand to move is not getting to the hand. But if you move this unaffected hand and you look into the mirror, assume is the hand, the brain is tricked into thinking that the affected side is moving. And it will now begin to send the impulses to the hand, that message to the hand. I now used those analogies, explained to the patient, and then the patient understood my perspective. And from then on, we started to do the exercise. So patient preference very important. You can have the evidence, it's high quality. If you don't know how to apply it, it's useless. You have the evidence, you know how to apply it. If the patient does not understand your perspective and agree with you and give you the consent, it's useless. So you have to consider all the three. I'm going to quickly go through the steps because I've taken a lot of time going through theory. I want to quickly go and look at some practical aspects. For you to do evidence-based practice, these are the steps. Number one, it's a clinical thing. You are seeing patient. You see an issue. You raise a relevant question. What is, or is smoking a risk factor for cardiovascular disease? Ask the question, because you want to ask questions to patients. Why do we always ask patients if they smoke or they don't smoke? Is smoking a risk factor for any disease? If I ask the patient they smoke, is that enough? How many sticks will they smoke for them to be at risk of having cardiovascular or cardiopulmonary conditions? What outcome measure can I use to assess inactivity in the multifidus muscle of a patient that has low back pain? Is infrared effective in the treatment of pain in the wrist of patient that has carpal tunnel syndrome? These are all questions. And I'm sorry I'm asking only relevant to physiotherapy because from what I saw, mostly people are physiotherapists. So I'm in the community, public health specialist. Is this patient that has been discharged capable of getting reintegrated into the community close to what he used to do before he got this injury or disease? Ask questions. Let it be a relevant question. Let it be a question that you are looking for answer to help the patient. The next step, search for evidence to answer the question. So this is something that is going to include a number of things. From the question, you are going to form what is called a search strategy. I will show you how to do the search strategy. From the question and the search strategy, you are going to select a database that you are going to go and search. I will tell you why our searches usually bring millions of articles that's so overwhelming that we cannot be able to search and get anything reasonable. I will show you how to narrow down the search strategy to give you something little that you can manage. Sometimes we get articles that are not good. They don't have quality because we go to Google. I will show you what databases that you should use that are acceptable, that can give you articles that have the quality to be acceptable for patient management. But just because you have a quality, the article, and you have fulfilled the first quality, which is using the research design, is an RCT. It has quality. It is a case study. It doesn't have quality. But that RCT, has it fulfilled the second quality? And this is where we now look at appraisal. Appraise evidence for quality, but not just quality, also applicability. My patient has weakness in the upper limb. I want to strengthen the muscles. And I want to use 10 repetition maximum, Delorme and Watkins. Is it Delorme and Watkins or Atkins or whatever? I can't even remember the names. It's long. Now we dealt with that. So what is the 10 repetition maximum? You give the patient weight, lift it 10 times, at the 11th time, get fatigued. I don't know whether there are advancements in these areas, that we have something new I've not checked recently. So the weight that gives you the 10 repetition maximum that you will use to strengthen that muscle, you will now use 80 or 70% of it as your intensity, and then you will now give that for 10 times, and then you will do that for a number of days in the week. If you get a paper that shows this dosage for strengthening exercise, will you use it? And that paper shows that the patients in that study were between 20 to 30 years. Will you take that procedure and give it to an 80 or 90-year-old patient? No, because of the degenerative changes in the muscles. If you give them 80% of that 10 repetition maximum, it may harm them. And therefore, for them, you may need another study that looks at 40 or 50% of the 10 repetition maximum. But instead of doing it 10 repetitions, you might add to make it 15 or 20 repetitions. But the intensity should come down so that you don't have something too heavy to injure their already degenerated muscle fibers. So this is what applicability is all about. I've gotten the evidence. I've appraised it for quality, is good. But is it applicable to my own patient? Because this is not a theoretical thing. I was seeing a patient, I asked the question, I get the result, I want to apply it on that patient. Is the result I got of the evidence of the research applicable to this my own patient with the characteristics that he has? Then after you have assured yourself of the quality of the paper and the applicability, then the next thing is to look at integration with expertise and patient values. And these are the second and third components that we are talking about. I will go and look at the methodology and read. I will learn how to apply it, just like I went away to learn how to apply that trunk impairment scale. I will then sit down with my patient. I will explain to him the concept, let him accept it. Then I will now begin to apply it on the patient. Then finally, there's what is called metacognition. This is something that we are going to discuss in detail in the course on clinical reasoning. Whatever I did, I want to go back and see whether there were mistakes so that in the next patient that comes, I correct them. So these are the steps. Remember, I told you that we are going to come back to these components of patient management. Because if you are going to ask questions that you will need to search to answer, then you must ask the questions across all the components of patient management. Whenever I teach evidence-based practice, if I ask students or the participants to raise questions in any of the components of patient management, mostly, especially physiotherapists that I've taught, because they are the bulkiest of the participants, mostly we ask questions under intervention. And I keep telling our colleagues, if you forget about clinical reasoning, your examination will not be helpful to make a diagnosis. And we don't look at prognosis. Our patients discharge themselves. We work like technicians. Someone has done the evaluation, come up with the diagnosis, sent to us, we only give the intervention. And I'm not looking down upon technicians. I never do, because I know I was in the UK. You will see a professor, a director, someone in the clinic, a superior person, will come to operate a machine. I'll say, please, where are the technicians? I don't know how to operate this machine. Please, can you come and show us how to operate this machine? Because that's what they do day in, day out. They know it more than the professionals. So they know things within their own scope of practice, more than we do. But the one that we are seen as experts in that area, we don't do it. We don't do evaluation. We don't interpret information. Our clerking is one page. We just put it information at the end. We have one package for every patient. And that is why a medical doctor will send a referral and you will say, give this patient ABC. Because that's what you do. That's what he sees you do. He doesn't see you do evaluation. And therefore, he's just giving you what to do. And you just go and do it. So we mostly ask questions at the level of intervention. We hardly do evaluation. We don't even know our own diagnosis. Many physiotherapists don't know what a physical diagnosis is. And if you don't have a diagnosis, how do you give an intervention that applies to that particular diagnosis? You'll have a general package that you give to everyone. Just give them breathing exercise and this and that, and that's it. I know things have changed. Our colleagues are doing very much better than we were before. But I think we need to have a lot of room to cover, a lot of gap to bridge. So we must ask questions. How do we ask the questions? The question must have 3 components. The question must have 3 things. Number 1, patient characteristics. The characteristic of your patient must be there, the relevant characteristics of your patient. Remember, in that case of the elderly person, a patient with weakness in the upper limb. But if you go and get an article that is in young people, it's not going to apply to that elderly person. And therefore, the age must appear somehow in an elderly person with weakness of the upper limb. So that's a relevant characteristics of the patient. Then outcome of interest. There must be something specific. I want to improve the strength of the muscle. I want to increase or relieve the pain. I want to increase the range of motion. So all this is looking at interventions. How do I assess pain? To assess range of motion. This is from the component of assessment or examination. How do I know, or how long does it take for this patient to be able to sit without support? This is from prognosis. What symptoms and signs put together can indicate a physical diagnosis of motor and sensory impairment in patients that have central nervous disease that is degenerative? This is a diagnostic question. And therefore, these are the 3 things. Number 1, patient characteristics. Number 2, the outcome of interest. What are you interested in improving? What are you interested in assessing? What recovery are you interested in seeing? What diagnosis are you interested in? That's the outcome of interest. Then the component of patient management must be delineated from the question. You may not see diagnosis, evaluation, examination, but from the way the question is put forward, is infrared effective in? The moment you hear the word effective, you know it's about intervention. Is VAS valid and reliable? You know it's examination. Is smoking a risk of? You know it's about risk factor. It's about examination. How long will it take a patient that has stroke to be able to sit independently? This is a prognostic question. So the way you put the question will determine what component of patient management you are looking at. From that question, you must see what the outcome of interest is, and you must have the patient characteristics. These are the 3 things that are important in any question that you raise, and it is that question that you are going to use to develop what is called a search strategy. And then you'll now go to a relevant database, you'll do the search, you will get the article, you will read the article, you will appraise the article, you will go to the methodology and learn how they applied the technique, and then you will go and study and get the practice how to apply it. You carry your patient along, and then you go back, you apply it on the patient. These are the steps of evidence-based practice. So I'm going to leave this because when we come back, we are going to do that. Let's take an example. I may not have a good example here, but whatever I have here, you are going to raise questions that will have characteristics of the patient. The patient has hamstring muscle tightness. So that's the characteristic of the patient. What is the effect of hamstring muscle tightness on exercise performance among patients with lower back pain? You have exercise performance, you have low back pain, which is lumbago. So it's the pain that you are after as the outcome of interest. So you have one category, you have two, you have three. How do you combine them? You use OR when you combine two words that are synonyms. So these are synonyms. So usually what you do, the first thing is when you have the word, you look for its synonym. Because the concept of search is that the search engine will go to the database and be looking at the abstract or the full text and see if those words appear. So if one study uses hamstring muscle tightness and another study uses hamstring injury, if you only put hamstring muscle tightness, the study that uses hamstring injury will not appear. And you lose that. So that is why you look for the keywords. What other alternatives are there? So if the study has this, but not this, you need it. If it has this, but not this, you still need it. And therefore, you combine them using O. The same thing with lumbar back pain or lumbago. These are alternatives you combine with O. But you don't want a paper with hamstring muscle tightness, but it is not in low back pain. Maybe it's in osteoarthritis. You don't need that paper. You also need hamstring muscle tightness to go with exercise performance. And therefore, you use AND to combine those three separate categories. For the synonyms, you use OR. But for those other components that all the three must be in that paper, you use AND to connect them. And we are going to see example. I'm just rushing to explain the theory so that we'll come back and use the example. So you have your search strategy. You want to go in to the databases to search. Remember in the hierarchy, we said the highest level of the hierarchy is the clinical practice guidelines. So if you are looking for clinical practice guidelines, you'll go to the National Guidelines Clearinghouse, www.guidelines.gov. But you may be disappointed because the rigorous nature of developing clinical practice guidelines has not made them to be very readily available for all conditions and all areas of practice. So don't be surprised if you search and you don't get them. But if you need them, this is where you go to. If you are looking for systematic reviews or meta-analysis, you go to the Cochrane Library, www.cochrane.org/reviews. That's for systematic reviews. Remember, they are the ones next to the clinical practice guidelines, meta-analysis followed by systematic reviews. For both of them, you can get them in the Cochrane Library. We are looking for randomized controlled trials. You can go to www.clinicaltrials.gov. But of course, there are other general databases where you can get all this. But if specifically the only thing you are looking for is clinical practice, randomized controlled trials, only RCT clinical trials is the one that houses RCTs. PubMed is a general one. It can give you all those types of research designs. PubMed is a search engine. It searches Medline. That is why here you will see PubMed comprises more than 30 million citations for biomedical literature from Medline. Medline is the database. Search engine, PubMed is the search engine. Medline is the database. Let me give you an example. You go to a physical library. You see shelves, there are books. The library with the books is the database. But when you go to the reception, because there are 1 million books, you don't know the one you are looking for where it is. You now go to the reception and you now see a librarian. And you say to the librarian, please, I'm looking for differential diagnosis textbook by so person, or I'm looking for discovering statistics using SPSS by Andy Field. Then the librarian will take it. He will now go into a rack and he searches and he sees the shelf. He now goes to the shelf and he checks the shelf. He brings out the book and he gives it to you. The librarian is the search engine. So just like that, PubMed is a search engine. It goes into Medline and it searches and it brings the article to you. You have CINAHL. CINAHL is for nursing and allied health sciences. You go to EBSCO, www.ebsco.com, and this is the link. When I set the slides, you can just go on the link and click it, it will take you there. Or you can copy and paste in your browser. Then ScienceDirect is another database, www.sciencedirect.com. Pedro is for physiotherapists. I know there are many physiotherapists on this platform. That's why I brought out the one that's relevant to only physios. If you are looking for an article that is only physio relevant, you go to pedro.org.au. Hooked on Evidence is also for physiotherapists, but only members of the American Physical Therapy Association can access it. It's called Hooked on Evidence, www.apta.org/patient care, evidence-based practice resources. Then TRIP. TRIP is also a search engine, but it searches about 20 different databases. So that's TRIP, www.tripdatabase.com. Then finally, the last and the least, you know, people will say the last but not the least. The last and the least is Google Scholar. Google Scholar is better than Google. Never use Google to search for articles that will apply on your patients. Never. Never. You know, all those people that just come up with websites and put in information that's a lie, or just their tradition. If you use Google, it will bring them. Say geography is a disease and the medicine for geography is this herbal, whatever, whatever. So Google Scholar is better because it only houses scholarly articles, journal articles, conference proceedings, textbooks, and other scholarly materials. But the problem with Google Scholar is that if you have a mushroom journal, someone just developed, you know, there are some journals that if you want to get promotion next week and you look at your papers, you have one paper remaining to get the points for promotion. You will sit down today, you will concoct data, you will write the paper. You will now send to that journal by evening, and they will say pay so $100. By tomorrow morning, they will ask you to go and download it. They have already published it. Google Scholar will bring you that journal and that article. But the other ones I've mentioned earlier, believe me, the process of getting indexed in those databases is very difficult, that if your journal is a mushroom journal, it can never scale through. And that is why you have more confidence in going to them to pick something that you are going to apply to your patients. We might use Google Scholar today to just test run how to get articles, because it's easier, you just go to it. But you have to be very, very careful what you get from there, so that you don't go and apply to your patient what is a lie. So these are the databases. So I'm not going to go into the critical appraisal now. Let me allow people to take a deep breath. In summary, this second session, what we have looked at are the steps for evidence-based practice. Number one, you raise the question. And as I've said, we need to raise the questions in the 6 components of patient management, because when we manage patients, we are not just treating them. We are assessing them, we are evaluating them, we are diagnosing, we are getting the prognosis before we give the intervention. And if we want to be professional, we need to look at all those levels of access to this site. Some are free, some are not free. Hooked on Evidence, you must pay to have access. Science Direct, you can do the search, but to get full articles, you have to subscribe. But Pedro, I think, is free. PubMed is free to search, but you need to subscribe to get full articles. So many of them are like that. So you raise the relevant questions from the components of patient management, 6 components of patient management. To do the search, number 1, you need to come up with your search strategy. Make sure your question has 3 components: patient characteristic, outcome of interest, and make sure it is very clear on which of the 6 components of patient management it's dealing with. You now pick a keyword from each of these 3, and you get alternative word that is a synonym. You combine the alternative words with O, but you combine these 3 different components with and then you now select a database. You use your search strategy to do the search. When you get the article, you read. You then do critical appraisal. So I will leave the critical appraisal until later. Possibly we might take a break. When we come back from the break, what we are going to do is just to go straight into developing questions, developing search strategy, selecting database, searching the database, obtaining the article. When we do this, then we'll now take a breath, and then we'll now look at appraising the evidence for quality and applicability. So let me ask if there are any questions at this point before we take a break. How about Medscape? Medscape, I think, is a search engine, but we can check and see. I wouldn't know all databases and all search engines, but I believe it should be either a search engine or a database, but we can check that. Any other question or comment? Sorry, I know I've spoken a lot. I've sent a lot of things. I hope it's not too much. I hope you are not losing the assimilation and things like that. Well done, thank you. Okay, I can't see any hands raised. So Dr. Jibrin, let me hand over to you to discuss how long the break should be, when we should come back and things like that. But when we come back, we'll just go straight into the practical. Okay. So not theory, just practical straight. Thank you.
Okay, thank you, sir, for the presentation. I think we are 15 minutes away from 2 now. Is it okay when we convene at 2:30? That's 45 minutes. Is it okay? Or too long?
I think it's fine.
Okay.
It's okay. It's okay, 45 minutes.
Okay. So we come back at 2:30. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, sir. Man, 2:30. Let's set around 2:25 maybe.
Right, you are welcome back. I think we agreed to continue by 2:30. So we are going to continue. And this time around, it's going to be practical, as I mentioned before we left. So it's also going to be, it's practical, but also it will be participatory. It's going to be an active thing that we're going to work together. So can we have participants post on the chat forum a question, a clinical question from the 6 components of patient management? So just quickly post one question each. Just choose a component of patient management and post a question. You're still waiting to see questions? Remember, question needs to have 3 parts: patient characteristics, outcome of interest, and the question must show what component of patient management the question is about. So we need to have patient characteristics, outcome of interest, and the question needs to have, or at least show, what components, which of the 6 components of patient management the question is directed to. So let's have questions, because I want to use one of the questions to help us develop search strategy, and then we'll choose the database and search the article, and then obtain the article. So still waiting to see questions. Is the break supposed to be much later? Are we really back? Dr. Jibril Samani, are we back? Hafiz?
We are back, sir.
Okay, okay,
We are
wonderful.
back.
Okay, great.
So far, 50 people have joined now.
Okay, great. Okay, good, good. Let's have questions. Let's have questions. Please don't worry whether the question is correct or not, because that's why we're here. We'll discuss. If it's correct, we'll just go straight to develop such strategy. If it is not correct, we correct it. Good, wonderful. That's what I'm looking for. So what is the best intervention for reducing pain in patients with post-stroke shoulder pain subluxation? So this for intervention. So what is the patient characteristics? post-stroke shoulder pain or subluxation. So this is the characteristic of the patient. Reducing pain is the outcome of interest. So because we are talking of best intervention is already there. So the question could have also been put in this format. Is okay, what is the best? So meaning you are not aware, you don't know which intervention. So that's good because it's a question, it's a problem. You have a patient that has post-stroke shoulder pain subluxation. What you want to reduce is pain, and you don't know what intervention. So that's okay. That's okay. So in another situation, it might be that you know what intervention you are dealing with, but you are not sure whether it's effective. So in that case, you have the intervention, you see whether that intervention is effective in reducing pain in post-stroke shoulder pain / subluxation. That's good. That is for intervention. So can we have another question? While we are trying to get another question, we'll discuss how to develop such strategy for this particular question. So let me open or possibly go back to, no, let me open a Word document and work with it so that I will share for you to see how. While we are working on this, I will suggest that all participants post their own. Okay, so I have a Word document open. I'm going to post the first question. What is the best intervention? So we said there will be 3 categories. So number 1, patient characteristics. Here we have post-stroke shoulder pain. So let's choose pain out of the 2. So let's choose post-stroke shoulder pain. Then we have outcome of interest. So let's say okay, outcome, okay, before say component of patient management. So it doesn't know what intervention, so we'll just put intervention there. Then the third is outcome of interest. What is the outcome of interest here? Is to best intervention for reducing pain. So pain. So these are the 3 keywords. So from all this, the problem is if you pick this and you put it in the search strategy, you'll see too many articles. And we are going to try. When we open the browser, we'll try. If we use this, what is the best intervention? The search engine is going to go to articles to see the ones that have what is the. And you know, millions of articles will have such letters or words. And therefore, you don't want any search that will bring articles that are not relevant. You want to get articles that have all the keywords in it. And therefore, we have removed post-stroke shoulder pain, we have intervention, we have pain. So the pain is the outcome variable. Or maybe let's use subluxation. No, let's use pain. We can try subluxation, post-stroke shoulder pain. So we want to relieve the pain. Now, can someone help to post? Is there any other synonym for post-stroke shoulder pain? Is there any other terminology that will be used in papers in place of post-stroke shoulder pain? Is there anyone that can respond to that? Any comment? Post-stroke shoulder pain. So should we say hemiplegic shoulder pain or hemiplegic shoulder pain? Yes, frozen shoulder, post-stroke subluxation. Okay, so frozen or frozen shoulder. I hope you are right. Are you sure? Hemiplegic shoulder pain, frozen shoulder, are they synonymous? Is that what papers will use? Because we are looking at alternatives to the name that papers can use. So let's assume that can qualify. Is there any other word that can be used in place of intervention? Any other word in place of intervention? Okay, shoulder pain following stroke. Okay, treatment. Or treatment. Good. Then pain. Is there any other word that can be used as an alternative to pain in papers? When people publish papers, if they don't use pain, is there any other thing they will use? Yes, treatment, that should be for intervention. Okay, discomfort. Okay, so let's try discomfort. Okay, discomfort. Yes, discomfort. So we now have part of the search strategy. The next thing is now to say, so we'll now pick the first part, which we already have combined using, I hope you can see the platform I'm working on, Word document. Yes, okay, wonderful. So we have post-stroke shoulder pain or hemiplegic shoulder pain or frozen shoulder. Then we'll now use and. Then we'll now put in the second part of the question. Okay, we close the bracket, we say and. Then we now pick the last part, which is pain or discomfort. Yes. So this is our search strategy. Post-stroke shoulder pain or hemiplegic shoulder pain or frozen shoulder, and intervention or treatment, and pain or discomfort. So let's copy this. First of all, let's copy the whole of this. Control copy. So we are going to now share the browser. So share the browser. So you go to your browser. Let's use Google Scholar first. So Scholar, Google Scholar, scholar.google.com. So you just type in scholar.google.com and let me paste that question the way it was. So let's see how many results we got. So it says about 48 results, about 48 results for that. So we are lucky we didn't get plenty. I was thinking we'll get millions, but now we have just about 48. So let's look through to see if there is any that is relevant. We are looking at shoulder pain. Well, see, when you have the subluxation, usually you'll have pain. So what they have in this paper is shoulder subluxation. So functional electrical stimulation. Remember, in your question, you didn't know what intervention to use. So they are now giving you the intervention. So functional electrical stimulation reduces pain and shoulder subluxation in chronic post-stroke patients. So this is relevant. If you look out to the side on Google Scholar, you are going to see PDF. This shows that the PDF is available. So let's open the PDF. I thought it was going to open in the browser, but it's not opening in the browser. So what this means is that I have to share that article at some point in time. So let me just save it. It has downloaded. I'm going to save it. Shoulder pain, functional electrical stimulation, and shoulder subluxation. So I'll save it in my documents so that when we finish looking at the options that we have gotten, we'll then, yes, we'll then go back and read through the article. So effectiveness of neuromuscular electrical stimulation for management of shoulder subluxation post-stroke, a systematic review with meta-analysis. So see, this is another interesting one. Now we are going to go in because this is intervention. I would like to see what research design was used in the first one. But for the second one, directly is saying that it is a systematic review with a meta-analysis. So we are going to see what that is all about. So let's open that too. This is saying ResearchGate. We have noticed since unusual. So are you a researcher? You need to log in. So let's see if we can have another alternative. So open it. So let's say all 5 versions. That will help give us different versions that we might get one that will open. Your browser is out of date. Okay, so I think what I will do is to copy and take it to a browser that will be acceptable. I will open another browser. Let me just copy the article. Then let me go to another browser and see if it will open. I have Chrome. So I'm out of that browser. You may not see what I'm doing, trying to see if I can open it using another browser, because I can see that it's an interesting article. It's an interesting one. I'm seeing full text search journal. So I think possibly that one is not available in full text. So this is what someone was asking earlier. Which ones are available? I can get the full abstract, but I'm having difficulty getting the full text for this particular article, which is on clinical rehabilitation journal. So, but maybe we can read the abstract letter. So, but let me go back. So let's see if there is any other article that is relevant. Number 2 is relevant, and it is a systematic review and meta-analysis. Number 3 is a book, Implementation of Evidence-Based Practice for Managing Post-Stroke Shoulder. But because it's a book, we know it's not high-quality research. I'm going to leave that. Painful hemiplegic shoulder. I have a feeling that this should be a narrative review. It doesn't look like a research article where evidence will be shown. I have a feeling that this should be a narrative review. So I will just open and see in case it is. It's a narrative review. So I will save that. Wonderful. It's a narrative review. It looks like a book, but it's an article, evidence-based review of stroke rehabilitation, or this is a chapter. It says 11, painful hemiplegic shoulder. Okay, I think, can you see the page that says 11 painful hemiplegic shoulder? Can you see that? Are we really together, or have I lost the network? Okay, okay.
Together, sir.
Okay, you can see it, right? Okay, wonderful, wonderful.
We are with you, sir.
Okay, wonderful. So painful hemiplegic shoulder, can you see this article? If you go through, you'll see if it is part of a book, then it will be a textbook. But if it is not part of a book, this is a good example of a narrative review. Remember, I told you narrative review will just have headings and explain concepts. So this is explaining what painful hemiplegic shoulder is, its incidence, its causes, then its pathophysiology, scapular rotation, pain in shoulder, subluxation, spasticity, rotator cuff disorders. This is a good example of a narrative review. So it is not really doing any randomized control trial or using any other research methodology. It is only stating concepts and facts about what the topic, which is shoulder subluxation, is all about. So this is not what we're interested in because it's a low quality research. We have also seen a book, we didn't open it, which is this, Implementation of Evidence-Based Practice for Managing Post-Stroke Shoulder. That also is a book. We are not interested in that. Shoulder pain in hemiplegia revisited, contribution of functional electrical stimulation and other therapies. From the look of it, this also is either a narrative review or a book. So if you look at painful hemiplegic shoulder, this also looks like a narrative review, but let's look at it. Oops, this is not opening. It's not opening. Let's see if this will open. This also is not open. So let's go next. Effectiveness of the California tripool taping method for shoulder subluxation post-stroke, a single subject ABA design. This seems to be relevant. The only issue is what type of research design is it? So let's open and see. So let's start with this one, looking at it. So we just want to see if it's relevant, it has what we are looking. Or maybe let's start with the earlier one, Kate A. Henry. So let's start with the earlier one, the one we got initially. So I'm going to share it. So this is the paper, Manual Therapy, Posturology and Rehabilitation Journal. So this is a journal. Remember, I told you that we have to be very careful with the Google Scholar because we are not using the database that screens articles and journals before they are indexed. But at this point, we are just trying to get through the process of how to use the search strategy to search in a database. Get the article, read through to see whether it's relevant to your patient. So that's what we are doing at the moment. At the later time, we'll now begin to look at the issue of the quality of the paper, whether to accept it or not to accept it. So it's functional electrical stimulation, reduces pain and shoulder subluxation in chronic post-stroke patients. So let's see the conclusion. What does it say? Okay, objective first. The objective is to analyze the therapeutic effects of functional electrical stimulation in the treatment of chronic shoulder subluxation in post-stroke patients. Our patient characteristics is post-stroke patient, so that's okay. The paper is okay from that perspective. What is our outcome of interest? Treatment of chronic shoulder subluxation. Remember earlier, the person that posted said pain or subluxation. So usually you'll have the subluxation, and as a result of that, you'll have pain. So, but this, at least we have the subluxation, and we know it is about reduction in pain, because I've seen it somewhere. Pain, reduces pain. So a functional electrical stimulation reduces pain and shoulder subluxation in chronic post-stroke patients, and therefore, because we are looking for pain, and the paper, the outcome of interest in the paper has to do with pain, so it's a relevant thing. And because we are looking at reducing a symptom, we know it's an intervention. We know it's an intervention, and therefore this paper is relevant. So what we'll do is to go to the conclusion. Let's see if they say it does that. Conclusion. Functional electrical stimulation associated with functional movements was effective in reducing the degree of subluxation of the shoulder joint and decreased pain in subjects in the chronic phase of post-stroke. So the conclusion has shown that it does that. But let's go to the methodology and see what research design this is. So method. This is a case study. Wonderful. Wonderful. Can you see what I've been talking about? From the caption, I thought it was a randomized control trial. From the caption, I thought it was a randomized control trial. But if you go down to the methodology, can you see where it says this is a case study? And remember, in the hierarchy of evidence, we said case study is at the bottom of the hierarchy. Right from this point, I'm not going to use this paper in the treatment of my own patient because I cannot generalize the result of a case study onto my patient. With blind evaluation conducted at the Faculty of Health Sciences at the Triary, Santa Cruz, Rio Grande do Norte, Brazil. It was approved by the Research Ethics Committee. The inclusion criteria, exclusion criteria, I want to see where they describe the patient. Say participants were randomly assigned to 2 groups. Can you see a red flag? How can you call it a case study? Okay, they say a case study with blind evaluation. So whatever this is, at the end of the day, I'm not going to use this on my patients. I can, if I have time, go through more and see how many patients they use. Patient 1, patient 2, oh, that's it. Patient 1, patient 2 in control group, patient 3 and patient 4 in treatment group. So this is more like a case series. This is more like a case series. So you don't have the number of patients are not enough for you to generalize the results to your own patient. I'm very happy that we even started with this. I'm not going to go further into taking this result and applying it on my patients because it's either a case series or a case study. So I hope this is clear. Therefore, I will leave this. I will leave this. So let me go back and see the one effectiveness of neuromuscular electrical stimulation. Okay, this is a systematic review with meta-analysis. So let me share this one. Let's see, at least from the abstract, if we can get something. Because if we can't get anything, then we have to get the full text. But let's see what we can be able to get from here. So effectiveness of neuromuscular electrical stimulation for management of shoulder subluxation post-stroke, a systematic review with meta-analysis. What is the objective? To examine the effectiveness of neuromuscular electrical stimulation for the management of shoulder subluxation after stroke, including assessment of short, 1 hour or less, and long, more than 1 hour daily treatment duration. Data sources. So in a systematic review, that's why they call it systematic. You go into many databases and you do use your search strategy, just like the search strategy we used. We used it only in Google Scholar. But a systematic review will use it across relevant databases. Remember, we said Medline was a database that has been searched using PubMed. There is Central. So remember, we talked about CINA for nursing and other allied health sciences. There is another one, WOS, Korea Med. Someone mentioned something, I can't remember it, they said whether it's also so. These are many different databases, RISS, and reference list from inception to January 2017, the review methods. So let's look at the results. 11 studies were included. Remember, I told you that meta-analysis and systematic reviews combine or pool studies and run another analysis on them. So 11 studies were included. 532 participants. If you go back to each of the individual studies from these 11 studies, you'll see that none of them is up to 100. Maybe it's 20, 30, 50 like that, but the total now gives 432, which is a very huge number. When you run an analysis on 432, whatever it gives you, you can be able to accept it, whether it says it's effective or it is not effective. So 7 studies were good quality. Can you see what I was talking about the critical appraisal? After the critical appraisal, they found out that 7 out of the 11 were good quality, 4 were fair. There was a significant treatment effect of neuromuscular electrical stimulation for reduction of subluxation for persons with acute and subacute stroke. Finally, after doing the meta-analysis, they found out that it was effective. And these are the statistical results with either short or long daily treatment duration. The effect for patients with chronic stroke was not significant. So acute and subacute stroke, they found that it was significant. But for patients that have chronic stroke, it's not. There was no significant effect of neuromuscular electrical stimulation on arm function or shoulder pain. So it was only significant on the subluxation, but it did not reduce the pain or the arm function. So this is what this systematic review has revealed. So if you want to use the result of this study, you can use it to relieve pain. You are not going to use it to relieve or to improve function. But if the patient has subluxation, you can use the result of this study to treat that subluxation, especially at the acute and subacute stage, because that is what this study has shown to be effective. The conclusion, this meta-analysis suggests a beneficial effect of neuromuscular electrical stimulation with either short or long daily treatment duration for reducing shoulder subluxation in persons with acute and subacute stroke. No significant benefits were observed for persons with chronic stroke or improving arm function or reducing shoulder pain. This is what evidence is all about. The study will show you the evidence. Now let's go back and look at, I think because it's an abstract, it's not giving us the full text. If it is giving us the full text, we would have gone back to the methodology and see whether in this paper we can see. Sorry?
Can we see the full text or no time?
No, that's what I'm saying. They have not given us the full text. So possibly you may have to, do you want to help us to get the full text?
Yes.
Oh, please do that and send to me, let me share. That's great, that's wonderful. That's wonderful. So Dr. Jibril Samari has access to full text of articles. So if you help us send it, then we'll be able to share and look at the methodology. Let's see how systematic review and meta-analysis look like. But one thing I'm going to do now is to go back and see if we can get an RCT before we look at the meta-analysis and the systematic review. Let's see an RCT. So let me share the document again. Yes, so this is the earlier search that we did. So what we'll do, why don't we go back and use the other search strategy? Because this one, we just used the general term. Let's go back and use the search strategy that we used earlier. Let's see what it's going to reveal. So remember, we had this one that says post-stroke. Good, so let me share now. Good. How many do we have? Almost 19,900. So it's even given more because of the search strategy. So remember the one that we have: post-stroke shoulder pain, or hemiplegic shoulder pain, or frozen shoulder. I hope I copied the whole thing. And intervention or treatment, and pain or discomfort. So see, the first one we have there says a randomized control trial of strapping to prevent post-stroke shoulder pain. So we have post-stroke shoulder pain, we have the intervention, but another additional information is that we know this study is a randomized controlled trial. And we said for intervention, this is where high quality begins. So let's just open that one and see what we have. Oh, your browser is out of date. So let me copy it and take it to another browser. So these are some of the things that you will continue to encounter. So usually when you don't have full text, it can give such problems. Scholar.google.com. Okay, thank you, Dr. Jibril. Effectiveness of neuromuscular. Okay, good. So let me share this one. Let's look at it from the top, because the meta-analysis and systematic review are the ones that are at the topmost level. So can you see the article? This is what Dr. Jibril Samani just shared with us. You got the full text of the article. The title is Effectiveness of Neuromuscular Electrical Stimulation for Management of Shoulder Subluxation Post-Stroke, a systematic review with meta-analysis. So this is what we read earlier, the abstract. So we just want to go through the article and see more information. So this systematic review was performed in accordance with the Cochrane collaboration. So they have a procedure for doing systematic reviews and meta-analysis. And the method protocol was registered with the International Prospective Register of Systematic Reviews. So usually you register so that you'll make sure no one has done that. You'll see the eligibility criteria, what articles were considered eligible, consider studies with participants with shoulder subluxation. So if they don't have shoulder subluxation after stroke in the articles, the randomized control trials used, then it is not acceptable with any stroke type, age, gender, social factors, or clinical setting. We excluded studies with participants with shoulder subluxation associated with other neurological conditions. So if the shoulder subluxation was as a result of brain injury, spinal cord injury, or cerebral palsy, they don't include that article in the systematic review. So these are just some of the things. Then the search strategy, identified by searching electronic databases. So these are the electronic databases they use. PubMed, remember Medline? Cochrane Library, remember Cochrane Library that we talked about earlier? There's another one. This is the CINAHL, Cumulative Index to Nursing and Allied Health Literature. Remember CINAHL that I mentioned? I said it's for nursing and allied health. So this is the full name, but the shortened form is CINAHL. There is Web of Science, there is KoreaMed, and Research Information Sharing Service, RISS. This is the full form of RISS. So they searched these databases using the following terms. So these are the search strategy or the keywords that they used: electrical stimulation, neuromuscular electrical stimulation, NMES, functional electrical stimulation, FES, shoulder joint subluxation, pain, motor function. These are the databases, but they put it in a search strategy like we did earlier. So there's a lot of information there, but let's see the statistical heterogeneity was assessed. This is all complex things, but at least you have information about what a systematic review is all about. So now let's look at the individual papers. The individual papers, let's see if this can turn around. Aha, good. So these are the individual papers that they used. Baker and Parker, this is 1986, long time. Design, 2-arm RCT. So it's a randomized control trial. The experimental group has 31, And these are the characteristics of the experimental group. The control group, these are the characteristics. And they had 2 NMES, and then the control, HAMI, sling, wheelchair arm support. So that's what they give to each group. And the outcomes, they assess subluxation by using X-ray, and then pain by using subjective self-report. And their result was that subluxation reduced significantly after treatment, and that there was no significant differences at the FU. Functional, I think that should be functional something. I've not read the paper, so I wouldn't remember, I wouldn't know what FU really stands for. Another paper they got in their search, Fagri et al. 1994, experimental and control group. What did they find? Well, their outcomes were subluxation using X-ray, motor function. What did they find? Subluxation reduced significantly, no significant difference at FU. So the initial one says no significant difference at the FU. The second one also the same thing, but the first one says subluxation reduced significantly. The second one also said significantly reduced. Now, what I'm trying to do is to see the individual papers, whether there are some that showed contrary result to the earlier ones, because usually that is what forms the basis for doing a meta-analysis or a systematic review. There's another one, Lin et al. In 1999, similar groups because they have 2, experimental and control. Subluxation, significant less subluxation after treatment, no significant difference at the FU. So this is similar to the others. There's another one, you might need to turn it around. So Wang et al., subluxation acute, reduced significantly. So now, can you see that in these ones, they were not referring to either acute, subacute, or chronic? So that's an interesting one. They just said reduce significantly. If we had gone by these individual studies, we would have thought that subluxation will reduce whatever type of subluxation or at whatever level, what stage it is. So look at this one just generalized. But by the time we begin to go down, we now begin to see that some studies like that of Wang et al. In 2000 and in 2002, they are now categorizing under acute and chronic. And they say in acute, reduce significantly, in chronic, no significant differences. And that's how it continues with all of them. So meaning there is contradiction, or at least there is no one statement. While the initial ones are saying, in as much as you have subluxation, is significant. But Wang at this point is saying that it depends on whether it is acute or it is chronic. And that is why they now did this systematic review and meta-analysis, pulling all the results. And at the end of the day, the primary data for these ones will also be categorized based on acute, subacute, and chronic. And when they completed the whole analysis, they gave this particular conclusion. That at the end of the day, it's only in short, at the meta-analysis suggests a beneficial effect of neuromuscular electrical stimulation with either short or long daily treatment duration for reducing Schobler's subluxation in acute and subacute stroke, but not in chronic. Not in chronic. So this is what a meta-analysis does. If there is conflict across the RCTs that are available, a meta-analysis or a systematic review will now run the analysis in the pooled data, and at the end of the day, give a result. So let's leave meta-analysis and systematic review. Let's possibly pick another example so that we can be able to see what an RCT shows. Another thing that I want to show to you is that in the RCT, how do we go to the methodology and read the intervention that they gave, learn how to use it, so that we'll now take it and give it to our patients. So let's just quickly go back and see the some of the comments that were made.
Hello, sir.
Yes, go ahead.
I don't know whether maybe it's not the right channel place here on the meta-analysis.
Okay.
The evidence, the grading of the evidence.
I think this is something that should go to that meta-analysis.
Systematic review. Yes.
The systematic review workshop. Yes. Because here, all I want is for people to understand how will they get the articles and how will they read it, how will they extract the method and apply it on their patients. Yes. So let's see another one here that says, what is the effective management of post-traumatic osteoarthritis of the coracoid process in a 45-year-old female presenting with pain and weakness of the shoulder region? But before we do that, let's go back to the other one and see if by adding systematic review, randomized control trial, we can get something. Because I just want us to read an article that is a randomized control trial. We'll go to the methodology of that particular article. So let's say stroke and shoulder subluxation and say electrical stimulation and randomized, or let's just say RCT. Good. So let me share this. I've gotten something that will serve what we are trying to find out. So this is a search. Can you see? It's just a simple search. Stroke and shoulder subluxation and electrical stimulation and RCT, which is randomized control trial. So let's open this and see if it will give us what we are looking for. So unfortunately, this is not an article that directly comes. I think this is a prepared article. It says manuscript. So possibly it has not been published. So let's see if we can get one that is published. Effectiveness of functional electrical stimulation. So can you see how frustrating sometimes it can be to search and get the information to apply to your patient? And therefore, when you do it and you think it takes you long before you get the article, just be patient. They are out there. It's just about searching and searching, screening, sieving, and then you will get something out of it at the end of the day. The effectiveness of functional electrical stimulation for the treatment of shoulder subluxation and shoulder pain in hemiplegic patients, a randomized controlled trial. So let's see this, if it is an article that has been published. Remember, this one is just a manuscript submitted. So if it is not published, we wouldn't just go and begin to use it for our patients. And this one is saying not found. So Malam Jibril, if you can help us get the full article of this particular one that we have gotten. Effectiveness, let me see if I can get any other one. Efficacy of electrical stimulation in preventing or reducing subluxation of the shoulder after stroke. This is a meta-analysis, which is another good one, meta-analysis, but we are looking for randomized control trial. Rehabilitation methods for reducing shoulder subluxation in post-stroke emparesis. This is a systematic review, randomized control trials. So mostly here we have systematic reviews and randomized control trials. The one that we have here that is an RCT, it is not yet published.
Submitted.
Sorry?
It's just submitted, but not.
It's just submitted, exactly. It has not been published. And we have to be careful because it is only when it is peer reviewed and it is published that we can say it is an evidence that we can now take it and apply it on our patients. So let's use something else. Let's use something else. Can someone just give an example or something that we can be able to get a full text?
We have a topic in the chat.
Okay, what's that? Read it out.
Yes, this one that says, this one on prognosis, I saw.
Okay. No, we have started the intervention. I want us to complete the intervention. Okay, no, I know what to do. Let's say stabilization exercise.
Okay.
Stabilization exercise and low back pain and randomized RCT. Because I remember the other time we got something very quickly using this randomized control trial of specific spinal stabilization exercises and conventional physiotherapy for recurrent low back pain. And stabilization exercise, so I'm looking for the one that has PDF. Trunk muscle stabilization training plus general exercise versus general exercises only. Randomized control trial of patients with recurrent low back pain. So let's see if this will show full text. Oh. I think I need to go back to the other browser. Let me use the other browser. So many a times you'll have to pay. Many a times you'll have to pay. And this is exactly what we're encountering. So doing evidence-based practice is not an easy thing. That's why in many papers you'll see when they say, what are the challenges? They will say the funding. You will get many articles that are free, but many others you will have to pay. So can you see this one also? Try to get it, sets PDF. And it's, so let's see, all 10 versions. None of them has full PDF, full article. This is a systematic review. Excellent post-session balance, a randomized control trial. So let's see this. Wonderful. Finally, we have gotten one that has a full text. Good. Finally, we have gotten one that has a full text. And this is a very big journal, good journal, BMC Musculoskeletal Disorders. It says effect of core stabilization exercise and strengthening exercise on proprioception, balance, muscle thickness, and pain related with outcomes in patients with subacute non-specific low back pain, a randomized control trial. So you are treating a patient that has subacute non-specific low back pain. This is the characteristic of your patient. And you are looking at whether core stabilization exercise is effective on proprioception, balance, muscle thickness, and pain. You can have all these problems of proprioception, problem of balance, muscle thickness, and pain when you have subacute non-specific low back pain. Now, what I'm trying to bring out in this, you have done the search, you have gotten the article. I want us to go first. Remember in the other articles we said, let's look at the conclusion. What is the conclusion? Because if the paper says it's not effective, why learn how to apply it? There is no point learning how to apply it. Now the conclusion says, despite both core stabilization and strengthening exercises reducing pain, core stabilization exercise is superior to strengthening exercise. This is interesting. We need this. Core stabilization exercise is superior to strengthening exercise. So meaning if we have a patient that has this problem, we'd rather give them core stabilization exercise. It is effective in improving proprioception, balance, and percentage change of muscle thickness, and reducing functional disability and fear of movement in patients with subacute low back pain, non-specific low back pain. So let's just quickly look at the methods. 36 of acute low back pain patients, these are their characteristics, were included in this study. They were randomly allocated into either, now this is telling us that there was randomization, randomly allocated into either CSE or STE groups. Exercise training was given for 30 minutes, 3 times per week for up to 4 weeks. If we are given this intervention to our patient, we must give that intervention for this, with this dosage, 30 minutes, 3 times per week for up to 4 weeks. Proprioception, standing balance, modal thickness of transversus abdominis and lumbar multifidus, and pain-related outcomes comprising pain, functional disability, and fear of movement were assessed at baseline and after 4 weeks of intervention. And they found out that they improved. Now let's go to the methodology and see how exactly did they apply the core stabilization exercise. These are the methods. Initially, they are describing the participants. So it's important, but because of time, I just want to quickly go to the procedure. And under the procedure, we are going to see the exercise. So these are the exercises. Another challenge you may have is that some papers, instead of describing the procedure, they will refer you to another paper. And that's another challenge. But let's see if this paper gives the description in the paper itself. Participants in the core stabilization exercise group received core stabilization exercise training using the treatment approach described. Can you see what I was talking about? Pontumetacul et al., with the exercise period shortened from 10 weeks to 4 weeks. Details of the CSE program are described in additional file, Appendix 1. So we'll go to Appendix 1 and see how did they apply it. There were 2 stages of CSE. In the first stage, which is week 1 to 2, the treatment emphasis was on isolating low load activation of the TRA and LM muscles with an abdominal drawing in maneuver technique. Subsequent training involved core contraction of these muscles in low load conditions. To activate TRA in the first week, the participants were positioned in prone lying. So now this is what I'm interested in. How did they apply it? And this is what I want you to see, to understand, to learn, and to apply on your patient. So the participants were positioned in prone lying on a bed with a small pillow placed under their ankles. So they're in prone lying, there is a pillow under their ankles. A pressure biofeedback device was used to provide visual feedback and was set at 70 millimeter mercury. It was placed under the participant's lower abdomen. So you are lying down, and they put something like the cuff of the sphygmomanometer. They inflated it to 70 millimeter mercury to provide visual biofeedback. The participants were asked to draw their lower anterior abdominal wall up and in towards the spine. If they performed the exercise successfully, pressure was lowered 6 to 10 millimeter mercury. So they will be looking at the SPIG and they will be seeing the changes in the pressure. If they are doing it correctly, successfully, there will be reduction in pressure by 6 to 10 millimeter mercury. Isolated activation of the LM was stimulated by raising the contralateral arm when performing ADIM, seated on a chair. Manual contact provided feedback for LM activation. In the second week, core contraction of the TRA and LM muscles with controlled movements of lower extremities was performed in supine lying and sitting positions. You now get to the second week. It also describes the procedure, what you do in the second week. Now, if you look at this, for me, that is not in musculoskeletal physiotherapy. I will think that I will need to study this, apply it on a subject, and it's very possible that I may even need someone to train me on how to apply this particular procedure. And that takes us into the second part or second component of evidence-based practice, which is practice-generated knowledge. I'm happy that we got this that does not look very simple enough for me just to go and apply it on a patient. I'm happy that I'm seeing something that will require me to study it, apply it on a subject, do it again, get someone to give me a feedback or give me a training before I now go back to my patient and I apply it. I know this has taken us over 1 hour, but this is the concept. This is what we are after. That patient that I saw, that I didn't do stabilization exercise, that the relative was questioning me, with this as an evidence, I will not just apply it, but I will apply something that has been shown in a paper that it is effective. And that paper is a randomized controlled trial, which is at the level of high quality research in the hierarchy of research evidence. Is there any question or comment at this point? Yes, love it, Annie.
Okay, well done, sir.
Yes.
Hello? Okay.
Hello, yes, I'm here. Go ahead.
Okay. Please, I want to ask if we should consider the year of publication while choosing the best evidence for our patients. Do we consider the year? Because there are some research that we went through that the year of publication was 1999. So do we consider such evidence while looking for the best for the patient?
Yes. You know why we have this thought that the year, you cannot use a particular year, it is in research. And in research, when you are reviewing the literature, our lecturers will tell us that there is a particular year where you can't include in your literature review. And I don't agree.
Okay,
I don't agree at all, and I'll tell you why I don't agree.
Okay.
Whenever you have an evidence that is the highest level, that's the highest level. In as much as there is nothing, no information that has come, because it's peer reviewed. And while it is there, no one has come to give an update on it.
Okay.
Then that information can be used. But the only time that information cannot be used, if someone in 2024 now does another research to refute that old research, to say that that old research is no more working anymore. This new one that I have published supersedes that one. Then in that case, you can't use the 1999 one. You must use the 2024 one. But no one has done any research to update the one in 1999. And the one in 1999, no one has shown that it will harm the patient. No one has shown that it is not effective. Why can't you use that? In as much as it's still effective and it can still help my patient, why wouldn't I use it? So you use it even if it is 1999. But if there is anyone that has done another study recently to show that that new study is an update to the one that was done in 1999, then that's when you use the new one. Or maybe if someone comes to publish something to say that, look, that procedure he used, now we know that it can be harmful to patients, then you also cannot use that. But if none of those two things happen, you can go ahead and use the data, the result of that study in your patients.
Oh, okay, sir. Thank you, sir, for clarification.
Okay. Ebubechi Anya.
Yes, please. Thank you. Thank you, Prof, for the wonderful presentation. It was very insightful. My question, I actually had two questions, but she asked one of them. And the second one I want to ask is, you know, you had come across a case study and we concluded based on the position on the pyramid that it's not going to be, the quality is very low, right? Yes. But these case studies, case series, they are people's hard work and they are published, they were reviewed, you know. So my question is, what then do we use them for? Like, if we can't apply them to patient management, why are they there? Like, what can we possibly then use case studies, case series, all those ones at the bottom for?
Okay. I don't know whether you muted yourself or someone muted you, but very interesting question. Okay, go ahead.
No, I was done actually. That's
okay,
why
you
I
are done.
muted
Okay,
myself.
wonderful. See, that's what is called a pilot study. If you have done a research, many people will do a pilot study before they go into the main study. What's the purpose of the pilot study? Can we apply it to our patients? No, we can't apply the results of a pilot study on our patients. Why? The purpose of a pilot study is to see if there are issues that you need to consider before you start the main study. So it's like it's educating you on the process. So that if, for example, the procedure is too difficult for the patients, you want to modify it. There is a procedure you want to do in standing, you say, well, why don't we modify it and do it in sitting? Because this category of patients cannot have that procedure in standing. Can the resources even be readily available? Okay, let's buy them. When we are using them, will it cost too much? If it costs too much on 5, and I'm going to have 70 participants, let me think of how to get more funding before I begin the main study. These are some of the reasons why you do a pilot study. The same thing applies to a case study. Remember, I was telling you, when I was discussing case study, I said, mostly it's when the new idea is developed. You said, well, let me test it on one patient. Let me see how it works. It's just for the purpose of that patient. It cannot be generalized. But is it not important? It's important because it is through that case study that you now see how you can be able to do a bigger study that can be generalized to every other person. So that's why you'll see in areas where there are no randomized control trials, when you review the literature, mostly what you are going to see in the literature are those case studies, case series. And that's what you use to build a case and a justification that there is need to do the main study. So it's not that it's not important. It's very, very important. When I was discussing the issue of expert opinion, I said people usually look down upon that. But the disciples of those people will say, look, let me put you to shame. If not because these people developed the idea, how can you even go and build upon it and get a systematic review or a meta-analysis? It is from their own hard work of developing the idea. It is still seen at the bottom of the hierarchy. But without it, you can never have any randomized control trial or systematic review. And therefore, it's important, but it's something that you build upon to get to the level of high quality. How do I?
Thank you so much, sir.
Yes. Thank you. Thanks a lot. Love it. Please, if you want to speak, go ahead. But if it is the earlier hand, can you put it down? There's a question here that says, how do I adjust my search strategy if I'm not finding relevant articles? See, there are times that, okay, two things. Number one, make sure you are using the keywords that researchers are using in their papers. That's number one. In as much as you know that you have used the relevant keywords, if you don't get articles, don't get frustrated. It's very possible that the researches have not been done in that area. The second thing after making sure you use the right articles, the right keywords, is to make sure that you use the right databases. You can't go to Cochrane to be searching for a case study, or to be searching for a cohort study, or a case control study, or a cross-sectional study. You can't get it. Because Cochrane website, it only gives you systematic reviews and meta-analysis. You can't be searching for a case control study and you'll now go to a clinicaltrial.com website. You can't get anything. So make sure, number one, that you get the right keywords. Make sure that you get all the possible synonyms that researchers can use. Because if this researcher used pain and another researcher used discomfort, you will get the article with pain, you are not going to get the article on discomfort. So make sure you get the right keywords. Make sure you have synonyms that are relevant that researchers will use. Make sure that you use the right database to do the search, and so on and so forth. If at the end of the day you can't get anything, it means it does not exist. What do? You now begin to develop a research in the area. If you can't do it alone, reach out to someone, maybe someone in academia. If you are working in the clinic, that does not mean that you can't be able to do a research, only that you need support from someone that has been doing research continuously, or that can do some part of it that is academic, and you do the part that is clinical. How do I know if a study is published or not? If a study is not published, but the article is out there, remember the one we saw earlier, a watershed, it says manuscript, submitted. So that is how you get to know. There's an article, it shows this is the article, but it will show submitted. Another way that you'll know whether it is submitted or not submitted, any article that is submitted is going to have a full reference in it. It will show the journal, it will show the volume, the number, and the pages. So the name of the journal, the pages that the article was published, the volume of the journal where the article was published, and if it has a number, because sometimes you have volume and number, say volume 1, number 12, volume 2, number 13, something like that. That is how you get to know that it is published or it is not published. Yes. So, okay, I can see another question. Okay, I don't know if it's published. Okay, good. So let's just quickly look at another example, very quickly. This example we are going to look at is going to be on assessment, because we have looked at a lot of, what is it called, interventions. So let's look at assessment. Can someone just give us an outcome measure and give us patient characteristic and an outcome of interest? I think someone just quickly give us something. I don't want to be the one bringing out this. Maybe even from the ones that have been submitted earlier, possibly. Yes, Akib.
Can we use Oxford muscle grading?
Okay, Oxford muscle grading for what?
For weakness, to assess the muscle strength.
Okay,
in
Oxford muscle
right lower limb
scale and muscle weakness and lower limb. So we don't have to put right. Lower limb will be okay, because I don't think using it in right will be different from using it in the left. So I'll just use lower limb, and I'll say and validity. I hope the one I'm working on is the one that is shared. So severity of upper and lower extremity functional limitation, scale development and validation with self-report and performance-based measures of physical function. So lower extremity strength differences predict activity limitations in people with chronic stroke, manual muscle testing and handheld dynamometer in people with inflammatory myopathy, and intra and inter-rater reliability and validity as studied. Reliability of isometric lower extremity muscle strength measurements in children with cerebral palsy, implications for measurement design. So I'm trying to see, okay, let's add something. Let's say, and cross-sectional study, because we don't have time to go through a lot of information. Cross-sectional association between muscle strength, current assessment of lower limb loading, patterns, mechanical muscle strength, and functional performance in ACL patients, a cross-sectional study. Concurrent assessment of lower limb loading, patterns, mechanical muscle strength, and functional performance in ACL patients. Quantitative assessment of cross-sectional muscle area. So because of the use of that cross-sectional, is giving us a lot of lower limb muscle strength and muscle mass, associated with incident symptomatic knee osteoarthritis, a longitudinal cohort study. Foot and ankle muscle strength in people with gout, a 2-arm cross-sectional study. Foot and ankle muscle strength. So, okay, sorry, I've just seen messages. Verbal rating scale in assessment of pain in elderly patients with low back pain. Okay, so that's another alternative, but let's first of all see if we can get anything on this issue of Oxford muscle strength. So let me remove the cross-sectional. I put it in there so that it will be faster to get the one that is cross-sectional. But let's just get what we can get, and then we'll now see if it is a cross-sectional study or not. Muscle weakness in hip, lower extremity strength. Differences predict activity limitations in people with chronic stroke. So this is not the assessment relationship between lower extremity muscle strength and all-cause mortality in Japanese patients undergoing dialysis. Can strength training predictably improve gait kinematics? A pilot study on the effects of hip and knee extensor strengthening on lower extremity alignment and cerebral, the relationship of lower extremity muscle torque to locomotor performance in people with stroke. So many of the ones that I'm seeing are more of prognostic. Gait characteristics and lower limb muscle strength in women with early and established knee osteoarthritis. So I'm looking for validity. Okay, let's say validity and Oxford muscle strength scale. Now, another issue is that what name is usually used for this Oxford muscle strength scale? What other words can be used? Validity. Muscle power. Muscle power. Well, the name of the scale itself. Muscle power is what is what it is measuring. So that's the outcome, isn't it? That's the outcome.
Okay.
Aha. So at least we have gotten something. We have gotten something. Inter-rater reliability study of the modified Oxford grading scale. So it's Oxford grading. Can you see what I was looking for? Another name that other studies are using. I was using Oxford muscle strength scale. But what they usually use in some other studies is Oxford grading scale. And that is why I was not getting it. And this one is a verify you are human. Verification successful. Aha, it's opening. That's what I didn't do earlier. I was having trouble. So let's look at this. To evaluate the inter-rater reliability of the modified Oxford grading scale and the Peritron manometer. So the Peritron manometer is also another way of assessing muscle power. All participants were evaluated twice, first by one examiner and 30 days later by a second examiner. Measurements of vaginal squeeze pressure were compared with the results from the palpation test. So what is the characteristics of the patient here? Because I can see where are our women's health? Vaginal squeeze. So you assess the muscle power of the vaginal muscles using this, isn't it? Either the Oxford grading scale or the Peritron manometer. So let's see, participants, 19 women with a mean age of, so it's for women's health. Inter-rater reliability for vaginal palpation was fair. Can you see what I was talking about earlier? The issue of the correlation. Sometimes they use R, sometimes they use what is called the kappa value, 0.33. Using the Peritron manometer, the difference between examiners was less than 10 cmH2O in 11 of the 19. The palpation test did not differentiate. So let's see what's the conclusion. The inter-rater reliability of vaginal squeeze. When we say inter-rater reliability, we are looking at someone assessing And when they come to assess later, they get similar results. Then we say the outcome measure is reliable. So the inter-rater reliability of vaginal squeeze pressure measurement using the Peritron manometer is acceptable and can be used in re-evaluations performed by different examiners in clinical practice. However, for research purposes, the ideal situation would be for a single examiner to assess and reassess the subject. Vaginal palpation is important in the clinical assessment of correctness of a pelvic floor muscle contraction, but this study does not support the use of the modified Oxford grading scale as a reliable and valid method to measure and differentiate pelvic floor muscle strength. This is something very interesting that I've seen in this paper. Don't use modified Oxford grading scale to assess pelvic floor muscle strength. But vaginal palpation can be used. Vaginal palpation is important in the clinical assessment of correctness of pelvic floor muscle contraction. So how can you give this vaginal palpation as a means of clinically assessing pelvic floor muscle contraction? Because they said, don't use modified Oxford grading scale to do that for the pelvic floor muscle contraction. So let's go now to the methodology and read about the process. So materials and methods, study design, these are the participants. This is the intervention. So intervention. An interviewer questioned the participants about their age. After verifying that the participants were eligible to take, I want to go straight to where they explained how to use the process. Vaginal palpation was performed using 2 fingers. The ability to contract and relax the pelvic floor muscles was first evaluated by palpation, asking the subject to pull her pelvic floor muscles in and up as strongly as possible and then to relax them completely. When a correct contraction was verified, the examiner scored it according to the modified Oxford grading scale. After vaginal palpation, the Peritron manometer was placed with the middle of the probe, 3.5 cm inside the vagina. The device was calibrated to 0 before each measurement. The vaginal sensor was not inflated. According to the manufacturer, inflation is an optional resource that can reduce the sensitivity of the sensor's response. The women were instructed to undertake 3 maximal pelvic floor muscle contractions sustained for 5 seconds with an interval of 30 seconds, as reported in a previous study. Only contractions with visible inward movement of the perineum were considered to be valid. Co-contraction of the gluteal and hip adductor muscles was discouraged, as was the Valsalva maneuver. At the end of the second evaluation, the participants were asked if they had done any pelvic muscle training between the 2 evaluations. This is also another interesting one for me because this is a procedure that I'm not aware of, and this is a study that's showing that it is effective in the assessment of pelvic floor muscles. It's not very clear to me right now, so I can't just take it and go to a patient. What I'm going to do is to study it more and more. Then I will try it in a subject. If I still think I cannot apply it properly, I will now ask someone who knows how to do it to teach me how to do it. And if I can't get anyone locally, the best thing is for me to now go to this paper and look at the address or the email address of those that used it in this paper. This is the email address, christine@fmrp.usp.br. I'll send an email to this corresponding author of this paper, or I will call this telephone number, +55 16360230058, and say that I read your article on pelvic floor assessment, muscle assessment. A very interesting one. I have patients that have similar characteristics with the patients in your paper. However, having read the methodology on how to apply the procedure on the patient, I still have difficulty understanding and putting it into practice. Please, can you guide me on how to get training to use this procedure? The person might reply to say that there is so person in Africa that came to do PhD and learn this procedure. Reach out to that person through this email or phone number, and then you'll get someone very close to you that can give you the training. By the time you learn how to use it, then you now go ahead and you apply it on your patient, and you continue to apply it on other patients that you'll be assessing. This is what evidence-based practice is all about. And I believe our CPDs should be reflecting this kind of things. When we read papers, whoever is organizing CPD, we can send them the article and say that, look, can you please consider having a CPD on the procedure of this article so that it can help us to apply it on our patients? This is what practice-generated knowledge is all about. And this is what evidence-based practice is all about. I don't know if you have any questions or comments at this point. Yes, I can see many hands. Is it old hands or is it new hands? If it is a new hand, just unmute and speak.
Prof, my question is regarding the search that we just made. You know, we put in like lower limb weakness and the grading system. So I was going to ask, do you reckon that maybe if we had added like an extra patient characteristic, like maybe a tibial fracture, that we would have,
wonderful.
You know, it would have been easier for us to find articles?
I agree very strongly. Your search strategy determines what you get or you don't get. I was just in a hurry to just get the article so that we can be able to go through it and see how we can extract how the procedure is done and how we can learn how to apply it to our patient. But we are going to have, as I've said, a session in the evening of, I think, Wednesday. Dr. Jibril, what day is it that we are having that practical session?
Yes, I think next Wednesday.
It's Wednesday, right?
Yes.
Yes, okay. So because on that Wednesday, there is not going to be any theory explanations. And what I did today, I did it myself. So we are going to have on Wednesday, the participants will do it themselves, only with guidance from the facilitators, possibly myself and Dr. Jibril. And remember, I told you what I did today is something that I do for 3 months, for a whole semester. So usually it's difficult within just an hour or two to do the practical for looking at the search strategy, searching, reading, extracting, critically appraising, and all that. It's difficult. And that is why this year we added one session that's going to be the practical session.
Yes, it's on Wednesday, 15th.
On Wednesday, exactly. So I think maybe by next year, Dr. Jibril, I think we need to have this kind of workshops as a course, especially by the time we get e-learning platform, so that we can have it to run for like 3 weeks. Every day there is a part that someone will read or listen to lectures, and over time they will be able to get a 3 weeks based training on evidence-based practice, for example, so that we can be able to exhaust as many things as possible, since it's really a very wide area. Yes, but thank you so much for that question. Any other question or comment? Okay, so in the absence of questions or comments, I think what remains is the critical appraisal. So possibly what I will do in just a few minutes is just to show how the critical appraisal is done. Then that's the theory part, and then the practical we can push it to the evening of Wednesday. So I'll just quickly share the slides. So we'll soon leave. I know many will be tired, but I just want to show us. Aha. So this is the website where you'll get the critical appraisal tool. I think the two articles that we looked at are one on assessment, looking at reliability or validity of an outcome measure, which is that for the pelvic muscle assessment. That's an outcome measure. It is under examination. And I think what I didn't do is to look at the methodology, the research design, which is going to be either cross-sectional or cohort. I think it should be a cohort or longitudinal study because they were assessing and then after 30 days, they assess. So whenever you have reliability, it can be a cohort study. Just like you can have a prognosis is also a cohort study. Validity usually comes with a cross-sectional study. But the paper we looked at on intervention, and I think it was core stabilization exercise, because it is an intervention, it was on randomized control trial. So that was the type of research design. Because the critical appraisal tools would depend on what type of research design you have. That is how you select the critical appraisal tool that is going to appraise that particular research design or that particular paper. So if you want to get the critical appraisal tools, you go to this website, caspuk.net. So I'm going to go out and quickly just go to the net, and maybe I will share that. So you go to another browser, you can say CASP. So CASP checklist. You click on the CASP checklist. It says CASP checklist. Then you are going to see the different research designs. Remember, we talked about cross-sectional studies for validity of outcome measures. Remember, we talked about case control studies for risk factors of diseases. We talked about diagnostic study for diagnosis, cohort study, longitudinal study. That is the one that I just mentioned, either for reliability or for prognosis. We also talked about systematic review. We talked about randomized controlled trial, systematic reviews that have meta-analysis of randomized controlled trials, and then systematic reviews with meta-analysis of observational studies. So there are so many different research designs that we discussed earlier. Let's open randomized controlled trial RCT. You can get it in Word version or in PDF version. So let me open the PDF version because it will open in the same browser. So what you do in the critical appraisal is to ask questions. Did the study address a clearly formulated research question? So you are either saying yes, no, or you can't tell. It's not clear from the paper. And what are the things you look at? Was a population studied? Was intervention given? Because if it is a randomized control trial, it must be about an intervention. Was a comparator chosen? Were outcomes measured? If you look at what is here, it's just like those three components of a question. You are just asking whether all those three components of the question are there in the objective of the study or the research question. Patient characteristics, outcome of interest, and then whether it is an intervention study. Was the assignment of participants to interventions randomized? Remember the paper that we read? There was a section that they were explaining the randomization. They will say there were 40 patients and we gave them numbers odd numbers go to experimental group, even numbers go to control group. If they did that, you say yes. If they didn't do that, you say no. Were all participants who entered the study accounted for at its conclusion? Someone was asking earlier that when patients start, they abscond. If you start with 40 and you need 40 to show significance or that the study shows effectiveness, if half of the patients drop out and you finish with 20, then you cannot be able to show effectiveness because you need 40 to show effectiveness. And that is why you need to show not just at the start, at the end, how many patients did you finish with? Were the participants blind to intervention they were given? So if I know for drug, you do blinding. For physiotherapy, you hardly do blinding. Because if you give this group treadmill and you give this group bicycle ergometer, there is no way you can blind them for them not to know which intervention they got. And that is why some of these studies, you'll say they are single blind, not double blind. Double blind is when you have researcher blinding. The person that did the assessment is not the one that gave the intervention. But then patient blinding is the one that you don't allow them to know what they got. For example, if it is a drug, you can have the placebo drug looking the same as the drug. It's just the constituent inside the drug that will differ, and the patient cannot see that. So the patient doesn't know which of them he takes, so that he cannot influence the result at the end of the day because he knows he took the intervention drug. Were the investigators blind to the intervention they were given? This is something that we can do. So did they do that? Yes or no? Me that assessed the patient, was I the same person that gave the intervention? Were the people assessing, analyzing outcomes blinded? So these are all questions. You keep answering the questions, and at the end of the day, you'll say that, look, most of these questions are answered no. They didn't do a good job, and therefore I'm not going to use it for my patient. This is what is called the critical appraisal. And remember, critical appraisal will depend on the research design for the paper. If you are looking at assessment of symptoms and signs, and you want to know if the outcome measure, such as the one that we looked at for vaginal assessment, if it is valid or if it is reliable, then you are using either a cross-sectional study or a cohort or a longitudinal study. And therefore, whatever you get, you will look for the critical appraisal tool for that particular design, and you use it to critically appraise it. If the answers keep saying no, 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 don't give it to your patient. But if the answers are yes across board, this is a very good one. Use it for your patients. So I think these are the theoretical aspects of evidence-based practice. In summary, we have looked at the components of evidence-based practice itself, say high-quality research, practice-generated knowledge, patient preference. We looked at the hierarchy of the evidence to see which ones are high quality, and we said high quality starts for interventions from randomized controlled trial, for assessments from cross-sectional study, for prognosis, cohort or longitudinal study, for risk factors from case control studies. And above that, everything is high quality. At the topmost level, we have the clinical practice guidelines, followed by meta-analysis and systematic review. And at the lowest level of the hierarchy, we have experience or expert opinion, textbooks, narrative reviews, case studies, and case series. We have learned how to ask a question in the 6 components of patient management. We have also developed search strategy. We have used the search strategy to locate the articles in databases. What we have not done is, after the Google Scholar, to use other databases. But this is something that we can do in the practical class that we are going to have on Wednesday evening. After getting the article, we'll go to the methodology conclusion to find out if it is an intervention, whether it's effective, if it is an outcome measure, whether it is valid and reliable. And then we now go to the methodology, the procedures. If it is an outcome measure, we see how it is applied to assess the patient. If it is an intervention, we see how it is applied to treat the patient. We have also seen the two assessment and intervention papers that we looked at, that they didn't look straightforward and very easy to learn and apply on patients. And we have agreed that there is need to study it more, test it on a subject, and if possible, find out an expert that can train us to be able to learn more about how to apply it to patients. Then we have seen how we critically appraise the paper to even know, apart from the first quality about the hierarchy, whether the methodology, they have used the correct methodology for the result to be acceptable. And finally, we have discussed the issue of patient preference. How do we carry them along? Make sure they accept our own preferences and the research preference, evidence preference, so that they can be able to cooperate and allow us to treat them using the evidence for them to get better. But finally, my call to all of us, number one, let's not just focus on intervention, treating patients. Let's begin to consider proper assessment. Let's begin to evaluate the results of assessment to make diagnosis. Let us consider what prognosis of patients are before we even plan their treatment. And when we treat the patients, let's follow them up to their communities to see if they are able to get back, reintegrated into their way of life before the injury or the disease. And lastly, whatever we have learned now and the practicals we'll do in the next session, let's go back and begin to apply them little by little. Every day we see a case, we look for an evidence, we come back, we apply. Doing that regularly is what is going to advance our level of practice. Thank you so much, everyone. May God bless you all.
Thank you very much, sir. We really learned a lot. We really appreciate it. Thank you, sir.
Thank you, sir.
Thank you, sir. So, if I may ask, what is going to happen on Wednesday that I went about?
On Wednesday, what I did practically, participants will do it themselves. And as they do it, they post on the chat forum their results. I will give them guidance and corrections. If they're having trouble doing it, they will ask questions, they will be guided. So it is not going to be a theory lecture like we have today that I spoke most of the time. It's going to be hands-on. So you will develop the search strategy yourself. You will post it, you will say it's correct. You will now go and look for a database. You will search, you'll get the article, you will read, you will extract, and then you will let us know how you'll apply it on your patient. You'll then do the critical appraisal. So everything is going to be done by the participants on Wednesday. We'll only be there to guide them and to give them some tips on how to do it better.
Thank you, sir. We're grateful. God bless you.
Yes, thanks.
No comments? Comment, question? Okay, I think people are tired since morning. Not So I think we can close. Okay. Can we close, Prof? You are done?
Yes, we are done. Yes,
okay.
Thank you. Oh.
Okay. So we thank everyone for. Okay, we have a comment, right? Okay. Thank you so much for participating, and we hope to see you. Our follow-up session will be on Wednesday, and then like that. So we hope to see you for subsequent sessions. Thank you so much, and bye-bye.
Thank you, Doc. God bless you.
Thank you very much, Prof. We really benefited a lot. Thank you.
Thank you, sir. Thank you very much.